yourself, and you'll do much better than second guessing. As soon as you say but, if you study, as soon as they eat but, you're dead. That's the best information I give you to how to pass.
You put pictures on your exam?
What?
You put pictures on
No pictures on the exam. You think this is going to be? No. I don't. Any of the pictures I showed you were there for your reference. You're never going to see a picture on any of my exams. Okay, when I was here last with pulmonary, we talked about the common cold and the treatment. Okay, we talked about pharyngitis and infectious diseases, so I'm not going over that. Next is peritonsillar abscess. The old name for it used to be quinsy. Okay, here you have bacterial invasion. Okay, through the tonsillar capsule, leading to a cellulitis and abscess behind the tonsil and the surrounding tissues. This does not occur in young children. The only time you really see a peritonsillar abscess is probably in adolescence. And what's the big deal if you have an abscess um, in the tonsillar fossa? What's behind the tonsillar fossa? Anatomically? No, where are your tonsils? The tonsils are right here. What's behind right here? What? The internal carotid oval sits right behind the tonsillar fossa. So we don't, second guess this stuff. The most common etiology is group A, baby hemolytic strep. Mixed anaerobes of pharyngeal flora can do it. Okay. These patients present with fever, sore throat, dysphagia, trismus. What's trismus? See, I use words and you shake your head and you have no idea what I'm talking about. What does trismus mean? Anybody? It means the inability to open up your mouth wide. That's what trismus is. So these people come in and they complain of a sore throat. They can't open their mouths. Okay, they have difficulty swallowing. And when you look in the mouth, the tonsil that has the abscess behind it is being pushed past the midline and maybe pushing the uvula over. And that's how you make the diagnosis. It's a clinical diagnosis. And the treatment for this is surgical drainage. You send them to the ENT just like any other abscess. They drain it, they needle drain it, and they put them on antibiotics. And then we'll talk about a little bit later what comes after that treatment. Okay? Then there's retropharyngeal abscess. Okay? And this is probably a true pediatric emergency in young kids. It needs immediate care. It's an infection in the retropharyngeal space, okay, of the lymphoid tissue back there. And the problem with this is, okay, it can dissect down into the superior mediastinum. And you really don't want to have to deal with an infection in the superior mediastinum. This is why it's an emergency. It's more common in boys than girls. And usually, my notes say, it doesn't happen after the age of 5 because the lymphoid tissue in the retropharyngeal space usually involutes as the kids get older. Of course, the only person I saw who had a retropharyngeal abscess was my father when he was 55. So my father didn't read the book. Okay. But this is generally a pediatric emergency. If you see it, okay, generally it's polymicrobial, group A strep, obviously being number one, and then staph and anaerobes can do it as well. The clinical manifestations, again, are very nonspecific. Fever, irritability, they drool, okay, because they have difficulty swallowing. They have a decreased oral intake, and they refuse to move their neck because if it's the retropharyngeal space, when they move their neck, it hurts. They may even present with a torticollis, okay? Their voice is muffled. They may have an inspiratory stridor, and they're seen in respiratory distress. Now, when you read the pediatric textbooks, it says when you look, you see a bulging posterior pharynx, but that only occurs in 50% of the cases. So I wouldn't even look for that. I would go with all the rest of the symptoms: drooling, muffled voice, stiff neck, refusing to move your neck. Okay, maybe stridor. Those are the ones you should pay attention to. And again, the treatment for these kids, they get hospitalized, they get IV antibiotics and surgical drainage. We covered sinusitis and otitis media, which are also part of the upper respiratory tract, okay? And then we talk about the good old tonsillectomies, okay? And the indications for tonsillectomies have changed over the years. When I was a resident, okay, the indication for tonsillectomy was one pair of tonsils and $375, and ENT would take out your tonsils. That was the indication. Okay, that's no longer the indication. Generally, we don't take out tonsils anymore. And in fact, tonsil and adenoid removal early on increases the risk for stress related disorders later on in life. This is a recent study from 2024. So again, we don't take out tonsils. And what was scary, I had my tonsils taken out in a doctor's office with ether anesthesia. Okay. And basically, I wonder how it made it. Okay. So, what are the indications for tonsillectomy? The absolute indication for tonsillectomy is airway obstruction secondary to tonsillar hypertrophy. Okay, if there's definite obstruction of the airway with hypertrophy of your tonsils, yes, we'll remove them. Or you have partial airway obstruction, okay, with chronic alveolar hypoventilation and the development of cor pulmonale. How do you make a diagnosis of cor pulmonale? It's an EKG diagnosis. So it means they're having EKG changes secondary to chronic hypoventilation. Those are the absolute indications for taking out tonsils. Okay? Probable indications if a teenager has had a peritonsillar abscess. That means the infection eroded through the tonsillar capsule, which means he's at risk for having it done again. If he gets another tonsillar infection, it may erode through again. So those kids, after they're recovered from the peritonsillar abscess, very often we take out their tonsils, okay? And perhaps tonsillar hypertrophy so big that it interferes with swallowing, it interferes with caloric intake, and the child has documented weight loss or failure to gain weight. Okay? Not grandma's idea that the kid is too skinny and he needs his tonsils out so we can fatten him up. Okay? Because grandmas have no idea what kids should look like. Oh, kids 5 to 9 years old should look like a bag of bones. You should be able to see their ribs. Their ribs should stick out because what covers your bones? Muscle or fat? What covers bones? Muscle or fat? Muscle. Well, kids don't develop, boys don't develop muscular hypertrophy till they secrete testosterone. And then you get the story with girls. Oh, she looked fine. Then she got a period, blew up like a balloon. No, she didn't look fine. Grandma thought she looked fine because she was nice and round, and then she hit puberty, got muscle hypertrophy, and the fat didn't turn into muscle. The muscle hypertrophied under the fat, and that's when, oh, now she's fat. No, she's not. She was fat when she was 5 and 6 years old. So we don't listen to grandma and take out tonsils for kids like that. They need documented poor weight gain or weight loss. Possible indications for tonsillectomy are repeat infections. What do we mean by repeat infections? 7 infections in 1 year, 5 a year for 2 years, or 3 a year for 3 years. And you have to document that these infections were, 1, caused by group A beta hemolytic strep, which means they were sensitive to antibiotics, that the patient had a history of fever, adenopathy, swollen glands that were greater than 2 centimeters in diameter, and that your antibiotic therapy got rid of the infection, that the parent followed your infection instructions and gave the antibiotics as documented. So if kids are supposedly having repeat infections, you start bringing them back after treatment to reculture them to see if, 1, it's not a continuation of the initial infection, or it is a second infection. So we make it very difficult to take out tonsils. Why? How do they take out tonsils? Anybody know? Basically, they use a garrote. They use a wire. They slip the wire over the back of the tonsils. They pull it tight. Now it comes. No big deal. Except we just told you what's behind the tonsil. So if you take a little bit too much of the tonsil and grab the posterior tonsillar fossa, you're going to rupture through the internal carotid artery. Or if you stop the bleeding and you use something like silver nitrate to stop the bleeding when you take it out, and you don't neutralize the silver nitrate can continue to erode through the tonsillar fossa. So kids have died from tonsillectomies. They go home and they bleed out on, after the erosion of the fossa. So again, tonsillectomies are very selective in removing them. Oh, the other indication of, well, not for tonsillectomies, for adenoids. Okay. All right. What about adenoids? Where are the adenoids? Can you see them on physical exam? No, you can't. Where are they? Where are the adenoids? Anatomically, where are they? They're up behind your soft palate between your nasopharynx and your pharynx. So the only way you can see adenoids is to put a mirror in the back of the throat and look up, or pass one of these fiber optic devices through the nose and look down. And that's what ENT does now with the fiber optic devices, is they look. Okay. So when do we take out adenoids? So do we take out adenoids? Well, how do we diagnose adenoid hypertrophy? Well, kids with adenoid hypertrophy have what's called adenoid faces. Okay, when you look at their mouth breathers, they breathe and talk like this. Okay, because they're all swollen up here and they have this funny looking face of talking. That's adenoid faces. Okay, and yes, if they have severe adenoidal hypertrophy where they're mouth breathing, where they have this funny speech, or if they have sleep apnea, okay, and snore. You know what sleep apnea sounds like? Okay, sleep apnea is a kid all night who sounds like this. Now the mother's running in the room to see if the kid's dead. Okay, that's what sleep apnea is. The sleep apnea, yes, will take out adenoids. Okay, how do they take out adenoids? It's a very sophisticated procedure. They just go up and they scrape the adenoids off the posterior pharynx. And because it's lymphoid tissue, if they don't give it all, it hypertrophies and grows back. So again, the only indication, probable indication for adenoidectomy are obstruction with sleep apnea or these adenoid faces. Sometimes ENT take out adenoids for chronic otitis media with an associated hearing loss, or maybe chronic sinusitis. Okay, they may take out the adenoids, but generally they don't. Okay, then the last of the upper airway is acute epiglottitis. Hope you never see this one. Okay, um, this is a real pediatric emergency. I was in practice for 6 weeks. Okay, and I'm examining a newborn, and from the waiting room, I'm hearing. There's a kid sitting by himself in the waiting room. I said to my secretary, "Who does he belong to?" "Oh, he's with the mother with the new baby that you're seeing." I said, "How long has he been doing that?" "Oh, it started this morning." I said, "Guess what? We're going to the hospital." Okay? This was Desmond. Desmond took 20 years off of my life, trust me, with him. He had acute epiglottitis. Okay? This basically it's caused by either strep pyogenes, strep pneumonia, or staph now. The most common cause of acute epiglottitis used to be Haemophilus influenza B. That was the most common cause in any patients we saw with acute epiglottitis. Okay, and with the vaccine, it disappeared. We don't see it anymore. Now that people are not vaccinating their kids, it may return. Okay, because Haemophilus influenza B is still out there. Okay, this usually occurs in children at the ages of 2 and 4. Okay, now it's basically in unimmunized kids or adults. These kids have a classic presentation. They start with a mild sore throat and very rapidly progress to acute respiratory distress, upper airway obstruction in a matter of hours. They have high fever. They're drooling. Okay. they refuse to swallow. They sit with a hyperextended neck leaning forward to try and straighten out the airway that the epiglottis is obstructing. Okay. And if they have stridor, it means pending complete airway obstruction. Now, the textbooks say there's a cherry red epiglottis. Don't you dare look for it. Don't you dare stick a tongue blade in this kid's mouth to see if the cherry red epiglottis is there, unless you're prepared to do a tracheostomy. Okay? And then they say, hey, a lateral neck film will show you the thumb sign, which is this thumb of the epiglottis extending into the airway. Now, in the bad old days, when we were taking boards, you could kill patients, okay? Because they would give a presentation of a kid with acute epiglottitis, okay? And they'd ask you what you would do. And then there was a highlighter, and you would highlight it, and they'd give you the results of every test you wanted to do for each particular scenario. And if you highlighted lateral neck x-ray for the thumb sign, and you highlighted it, it said, patient died in x-ray, go on to next question. Okay? Because you never take an x-ray of these kids. Okay? They belong in the ICU, they belong intubated, and they belong on a ventilator. And then steroids to reduce the swollen epiglottis and antibiotic therapy. I don't care what the neck x-ray looks like. Acute epiglottitis, these kids will die. And that was Desmond. So I took him to the ICU, I intubated him, put him on a vent, he got better, he went home. He subsequently developed asthma, pain in the ass with that. And then about 5 years later, he's 9 to 10 years old. He comes in, his eyes swollen, his lips swollen. He had an acute anaphylactic reaction to sardines. Back in the ICU, intubated on the bed. That was Desmond. Okay. 20 years later, this big African American cop walks into my office. Where's Dr. Emmett? So what's everybody's first response? What the hell did I do wrong now? Okay. That was Desmond. He was doing his taxes across the street. He saw my new office, came in just to say hello. Nothing more to scare me again for the third, that kind of thing. But you never want to see acute epiglottitis, okay? The treatment is immediate hospitalization and respiratory care because these kids quickly become hypoxemic and they die. So I hope you never see this one. Who knows what's going to happen with the lack of immunization? But they require, intensive care management. That's the end. No, that's not quite the end of upper airway. Then we get the croup syndromes. Okay, croup is defined as an acute infectious disease, maybe non-infectious, characterized by barking or brassy cough, associated with hoarseness, inspiratory stridor, and maybe some respiratory distress. It depends on which one it is. So the first one is acute spasmodic croup. Okay, we have no idea what causes it. Okay, maybe allergic, maybe viral, maybe there's psychological factors. This is the 2 o'clock in the morning call. Okay, you get called in the middle of the night. There's a hysterical parent on the phone, and you hear flipper in the background. That's what you hear. Okay, that's croup. Sounds like there's a seal barking in the background. Okay, the child is generally afebrile. There's no other findings except he sounds like a seal. Okay, and generally they're young. They're usually between the ages of 1 and 3. And basically, if you do nothing, it's going to improve over several hours. Okay, but they may stay hoarse for a couple of days. The treatment for these kids is stop being hysterical because the more upset you get, the worse the kid gets. Okay, and take them into the shower and steam them. High humidity helps these kids. And if you calm them down and sit there in the shower and let them inhale the steam, if you have a nebulizer, you give them saline. High humidity works great for these kids. Okay, in the dark ages when I was a resident and working 140 hours a week on our days off, we were covering house calls for the pediatricians on staff. Like we didn't have enough to do, okay? And it was this miserable, nasty night. And I get a phone call, okay? And you hear Flipper. And this mother didn't want to hear what to do. She wanted to visit. Okay. So I said, I'll be there in 20 minutes. It's nasty, cold, and raining. I said, take the kid out in the carriage. I'll be there in 15 minutes. Okay. And of course, it's 2 o'clock in the morning. I get there, and here's this woman with an umbrella wheeling a kid around in this nasty, cold, rainy weather. And by the time I got there, the kid was fine because that was the treatment. I said to the mother, you must be Mrs. Smith, the only idiot out with a kid at 2 o'clock in the morning. And that was the treatment. So that's the treatment for acute spasmodic croup. Now, acute laryngotracheitis. This is the one, if you're working in the emergency room or urgent care, you're going to see. And an old-time pediatrician told me, the kid that wakes you up at 2 o'clock in the morning, you never have to worry about. The kid who starts coughing at 10 o'clock in the morning and gets progressively worse as the day goes on, that's the one you're going to see in the office or in the emergency. Okay, this is the most common and typical form of croup. Usually, they have a viral illness for about 1 to 3 days with a low-grade fever. Occasionally, they have no fever. Sometimes they're running high temperatures. They have the barking cough. They have the inspiratory stridor. Okay, they develop respiratory distress. Okay, and of course, you bring them to the worst place in the world, the emergency room, where everybody is attacking them, listening to them, doing everything under the sun. And the more agitated the kid gets, guess what? The worse his cough's going to be. Okay? So these kids should put in a quiet place, and basically you should do as little as possible. Okay? You listen to them, you see what's going on. The kid generally doesn't look toxic. He doesn't look like he's in significant respiratory distress, but the more agitated he gets, the more barking he's going to do. Okay? And basically, the treatment for these kids is inhaled steroids. Okay? And I don't care how you give it. You can give them a shot of dexamethasone. You can give them oral dexamethasone. You can give them inhaled steroids through a nebulizer. Any way you do it, the steroids will decrease the swelling and they will get better. They will probably remain hoarse for a week or two, but they won't be in any respiratory distress, and they won't need any more steroids. One set of treatment is enough, and these kids do fine. Now, the other two are extremely rare, and I really haven't seen many of them, okay? Laryngotracheal bronchitis is a secondary infection of a kid who presented with laryngotracheitis, okay? This doesn't occur in the normal pattern of 1 to 3 days of an upper respiratory illness and then the barking cough. This occurs 5 to 7 days after the kids have the barking cough. After you've treated the barking cough, now they get a secondary bacterial infection, okay? And these kids may look like a kid with acute epiglottitis. They may present with now inspiratory stridor. The barking cough may return. They may be sitting in the tripod position because they want to straighten out their airways. Okay, and these kids need basically antibiotics. The last one is not part of the croup syndrome. This is a bacterial tracheitis. This is an acute bacterial infection of the upper airway, excluding the epiglottis. Okay, so it's a tracheal infection. Okay, Staph aureus is the most common etiology for these. Okay, these patients suddenly develop again another high fever. They develop the brassy cough. They come in respiratory distress, but they don't have difficulty swallowing. There's no drooling. Why? Because the epiglottis is not involved, so it's not including the esophagus. It's further down, and when they cough up pus. So, and I've never seen this one. So, this is extremely uncommon, but we sort of dump it into the tracheal syndrome or the croup syndrome because they have the same barking cough. For typical croup, it's airway management, high humidity. You can use racemic epinephrine for patients who are unresponsive to cool mist or steroids, okay? And you're saying, yeah, this kid's becoming hypoxic, maybe we ought to intubate him, let's give him a course of racemic epinephrine. If you do, you got to keep in the emergency room for 2 or 3 hours, because after the racemic epinephrine wears off, the symptoms may come back, but at least you bought time for the steroids to work. Okay? Antibiotics are not indicated in any of the group syndromes except for maybe laryngotracheal bronchitis or bacterial tracheitis. That's maybe where you're going to give antibiotics. That takes care of the upper airway. Okay? Now we start with the lower airway. Okay? And we start basically with bronchiolitis. And bronchiolitis is a viral disease of the lower airway. And the problem with bronchiolitis is it's just not a viral infection of the lower airway. There's an increased immunologic response. And the increased immunologic response in these kids, okay, results in edema, okay, increased mucus and cellular debris. And that's why these kids get into trouble. Okay? Remember, these kids have a narrow airway to begin with, so anything that narrows their airway is going to cause greater trouble. For exam purposes, the most common cause of bronchiolitis is RSV, respiratory syncytial virus. There's far and away more than 50% of all cases of bronchiolitis is caused by RSV virus. Okay, there are others, parainfluenza, adenovirus, mycoplasma, may do it. If you see a patient with RSV, with bronchiolitis, it's RSV. And it's interesting, RSV was first isolated from monkeys in 1956. And a year later, it was isolated from kids. Didn't take long for this virus to spread, okay? Because this virus is highly infectious, okay? It can last on countertops for more than 6 hours. It can last on your gloves for 90 minutes and on your gowns for 30 minutes. And if you don't wash your hands, it's on your hands for 25 minutes. It doesn't go away, okay? Once they get the infection, they continue to shed it for 6 to 7 days in healthy children, and in immunocompromised children, they can spread this virus for about 6 weeks. The incubation period is about 5 days, okay? And basically, all children are infected with RSV. 50% of children by the age of 1 have been infected with RSV, and 100% of children by the age of 3 have been infected with RSV. The peak range is typically 2 to 8 months of age. Obviously, it's severe in younger kids like 1 to 3, because they have the smaller airways. They are basically more susceptible. Okay? Generally, it occurs in winter and early spring. And I can tell you, if you're working in urgent care or the emergency room, and it's the end of October and beginning of November, and you see your first case of bronchiolitis, be prepared for the onslaught. Because once somebody shows up with it, the parade of RSV is basically going to show up, okay? There are basically 250,000 emergency room visits every year for RSV, and that don't include the kids who show up in the doctor's office who aren't basically that sick. These are the young kids who show up, okay? And there are over 130 hospitalizations every year in children under a year of age with RSV. That's a lot of kids showing up in the emergency room, okay? And they estimate, and this is just in the United States, okay? Worldwide, there are 3 to 4 million patients for RSV worldwide. So the cost, you want to know why your insurance rates are so high? The cost of RSV here in the United States It's $1.78 billion every year for these kids who are hospitalized. Okay. And 40% of patients in the hospital who aren't there for RSV subsequently get infected with RSV when it starts running around in the hospital. So this is a big problem. Now, who is at greatest risk? Okay, obviously, the younger the kids. Children under 2 months of age are at greater risk. Low birth weight babies, babies who weigh under 5 pounds are at greater risk. Ex-preemies, anybody born less than 30 weeks gestation. Okay, and then they say adults under 40 or over 70 are at greater risk also. Okay, um, children exposed to cigarette smoke in the house are also at greater risk. Any child with underlying cardiac or pulmonary disease are at greater risk, or those with major congenital anomalies. Large families and crowded households, because once somebody brings it home from school, everybody's going to wind up with it. Okay. And basically, if there's a history of atrophy in the family, these kids are at greater risk as well. Um, these children usually present with a mild upper respiratory infection, maybe have a low-grade fever, and then 1 to 2 days later presents with tachypnea, wheezing, irritability. They're feeding poorly. They show evidence of respiratory distress with nasal flaring and intercostal, basically retractions, maybe rails, but wheeze is the number one problem. Okay, 1% die from this due to apnea and respiratory acidosis and severe dehydration. There is a rapid test for it, a nasopharyngeal swab, and we'll go into why it's not necessary. We can now prevent this. Okay? Years ago, there was a drug that came out that was called Synergis, and we gave it to ex-preemies and kids with chronic pulmonary disease or low birth rate infants or children with congenital heart disease. It was an injection given from October to April, and the cost was $1,600 a dose. Well, if you figure it out, $1,600 a dose for, um, no, November, December, January, February, March, April, 6 months is about under $100,000. One day in the ICU is more than $100,000, so that's why it was given. But that was no longer used. Okay, now we have an immunization to prevent it. It's a monoclonal antibody called Beyfortus. Okay, and we give it to all children now. Okay, especially those at high risk, and they're recommending it to pregnant women because if you give it to pregnant women, they'll pass the antibodies to their infant after delivery, which will cover them for the first 3 months, which are the kids at greater risk for developing RSV. So this is the immunization out there, and basically it's highly recommended to prevent it. Now I said it was recommended for adults over 70 also, because old farts can get it as well. Well, when this immunization first came out, I went to the manufacturer and I said to him, "Let me ask you a question. I've been taking care of babies with RSV for 50 years or more. They've been coughing in my face for more than 50 years. Don't you think I've developed some sort of immunity to RSV?" And the response was very interesting. That's a very interesting question. We didn't study it. Of course you didn't study it. You wouldn't make money if people like me didn't take the immunization. Okay? But basically, I haven't taken it because by this time I figured I've coughed on often enough for kids with RSV that, I have some sort of immunity. So, how do these kids present? You said poor feeding, okay? Wheezing when you listen to them, okay? So, what's the treatment? Basically, the only treatment for RSV, once they get it, if they're showing signs of respiratory failure, let's say if they're under 2 or 3 months of age, they get IV fluids and they get high humidity um, breathing. So how do I treat these kids when I get them in my office? Okay, I don't order a pipette from surgical supply house to be delivered to the house with compressed air, so we can give it to them. If I did that, with the 50 patients a year I see, the insurance companies would throw me off the panel. So basically, you make one. If the kids are over 3 months of age, they're really unlikely to develop respiratory distress like the younger ones do. So what do? If the kid is respiratory rate, let's say, is 60 or less, okay, and they're taking fluids and they're not showing signs of respiratory distress, I send them home and I tell the mothers to take a humidifier and put it right alongside the crib and then put a towel over the top of the crib so all the humidity rains all over the kid. Because that's what we do in a cribette. Okay, it's high humidity. The humidity rains all over the kid, and you just say, take receiving blankets, changing them. Okay, and most of the kids get better. Okay, so I mean, I haven't admitted a kid with RSV in years with this sort of treatment. As long as they're taking fluids, and as long as you keep the high humidity up, they do very well. Now, what we don't do, there was an article in the New England Journal that came out about 5 years ago now. Okay, here's what's not necessary in the treatment for patients with bronchiolitis. Bronchiolitis is a clinical diagnosis. You do not need an x-ray in these kids. In fact, you don't even have to do the nasal swab to prove that it's RSV because the kids come in looking like they have RSV, and the only reason you want to do the nasal swab is to make more money. Okay? So basically, no x-ray, no nasal swab, no bronchodilators. This is very interesting. When I was a resident, we didn't use bronchodilators for kids with RSV because we were told that there were no receptors for beta agonists in the airway, so it was a useless job to do. Then as time went on, we started trying beta agonists in the nebulizers, and I don't know whether it was the beta agonists or the high humidity from the beta agonists that helped these kids. Now the current recommendation again is no beta agonists. It doesn't work. Okay, no steroids. Steroids do not work on these kids. Okay, and no supplemental oxygen is necessary if their oxygen saturations are above 90%. But then they said in the emergency room, do not do oxygen sats because if you do oxygen sats in the emergency room, they're going to wind up there longer than necessary because the kids look fine, but their oxygen sats don't. So I guess if they're hospitalized, we do oxygen sats. In the emergency room, they don't recommend doing it because it prolongs emergency rooms and hospital stays. No antibiotics because it's viral. No chest PT is necessary. Okay, no racemic epinephrine. So basically, it's high humidity and IV fluids. Okay, the only thing that might work is hypertonic saline nebulizer, 3% sodium chloride nebulizations. And why does that work? Because it's a hypertonic solution, and when you blow it down the airway, it's going to bring more moisture into the airway, loosen the mucus, and help these kids cough it up. But that's the only indication for treatment of bronchiolitis. Okay. In the past, there was a drug called ribavirin that was used for the treatment when the kid came into the hospital in respiratory distress. It was given by nebulization. It supposedly helped the treatment. Okay. It was teratogenic. And who was giving these kids their nebulized ribavirin? Nurses, many of them who were going to be or pregnant, so we no longer use ribavirin either. So currently, the only prevention we now have is prebornis, okay, and it's working wonders in currently treating these kids for bronchiolitis. And this one you'll definitely see. There's no question. First of all, the immunization rates aren't that high with the current standard of the people who are anti-vax of any sort whatsoever. So we still will see bronchiolitis. We haven't eliminated that one yet. Hopefully in the future we will. Okay. After RSV, the next lower respiratory tract infection that we talk about is pneumonia. Okay. And we define pneumonia as inflammation of the lungs, generally by microorganisms. Bacteria can do it, viruses can do it, aspiration of food or gastric contents or foreign bodies can give you inflammation, and hypersensitivity reactions or drug reactions can give you inflammation of the airways. Okay, pneumonia is common in younger children, usually under the age of 5. The incidence of pneumonia is about 40 per 1,000 children. Okay, once they get into the teenage years, okay, it drops from 40 per 1,000 children to 7 per 1,000 children. So the incidence decreases. The etiologies vary by season, okay, and varies by the age of the patient. Okay, risk factors for pneumonia: lung disease like asthma or cystic fibrosis, GERD with aspiration of the reflux stomach contents, neurologic disorders which the patient is unable to cough and clear the airway, or immune disorders or hemoglobinopathies increase the risk of them developing pneumonia. So we said it varies by age and season. So basically, children under 3 months of age, the most common non-bacterial etiology for pneumonia is RSV. Okay, that's the number one on the list. Yes, chlamydia can do it, cytomegalic virus can do it, as well as parainfluenza and influenza. Under 3 months of age, a kid comes in the winter, okay, and he's wheezing, and you may hear rales, he's in respiratory distress, it's RSV. Bacterial etiologies under 3 months of age, you know that one. We talked about that one in the past. That's group B strep. Staph aureus can do it, yes. Klebsiella, yes. Group B strep, under 2 months of age, under 3 months of age. That's the most common cause of bacterial pneumonia in infants and young children. 4 months to 5 years of age. Now we got the older kids. Non-bacterial, we're back with RSV, particularly in the winter months in patients who come in respiratory distress who are wheezing. They have RSV. If it's in the flu season and they come in with evidence of pneumonia, what's the clinical evidence of pneumonia? When you listen to the chest, what do you hear? Rales, crackles. When do you hear crackling? On inspiration or expiration? Huh? When do you hear crackles? You hear it on inspiration. It's air going through the fluid of the inflammation. When do you most often hear wheezing? Inspiration or expiration? Expiration initially. What the hell are rhonchi? We got rales, we got wheezing, then we got rhonchi. Rhonchi are generally upper airway noises, and it's heard both on inspiration and expiration. And that's basically how you differentiate all the noises when you're listening to the lungs. Okay, rhonchi are just gurgling while the kid is breathing. Okay, so if it's winter and you hear rales and the kid's not wheezing, it's influenza or parainfluenza. If it's winter and they're wheezing and they're 4 months to 5 years of age, it's RSV. Okay, parainfluenza occurs in the fall, spring, and summer, so it's not flu season. It's not RSV season. That may give you a diagnosis of viral pneumonia. Okay, and then adenovirus T cells and HIV can give you clinical evidence of viral pneumonia. Bacterial pneumonia in the 4 months to 5 years of age group is strep pneumoniae or pneumococcal disease, number one. Unfortunately, now they're also reporting mycoplasma in kids 2 to 4 years of age. Okay, so mycoplasma pneumonia may show up in these kids 2 to 4 months of age. But what's the hallmark of mycoplasma pneumonia? Anybody know? These are kids who wheeze. Okay, they have wheezing and you hear rails. They may have a cough. Okay, and the reason we tell you about mycoplasma is, what's the only drug that works for mycoplasma? The microlides. Why? Why doesn't antibiotics work for mycoplasma? Huh? What is atypical?
Cell wall.
What?
This is the cell wall.
It doesn't have a cell wall. Mycoplasma does not have a cell wall. Okay. All the other antibiotics are bactericidal because it destroys the cell wall. What are the macrolides? Are they bactericidal or bacteriostatic? They're bacteriostatic because they don't work on the cell wall, so they slow the growth of mycoplasma. Okay, they're bacteriostatic, not bactericidal. Okay, and then older kids, over the age of 6. Okay, mycoplasma influenza adenovirus cause viral pneumonia and bacterial pneumonia, strep pneumonia, Staph aureus, group A beta hemolytic strep. Okay, are the bacteria that are responsible. So, basically, what are the clinical manifestations? Depends on the age of the kid. Okay, infants have minimal systemic signs. They generally have, respiratory signs: nasal flaring, respiratory distress, tachypnea, grunting, retractions, no cough. That's typical of infants. Older kids with pneumonias tend to have more systemic signs: high fevers, shaking chills, okay, chest pain maybe, dry hacking coughs, okay, and how do we differentiate viral from bacterial pneumonias? Okay, or do we? Do we have to treat all pneumonias or lower respiratory tracts with antibiotics? And the answer is no. Okay, a study for treating pneumonias or lower respiratory tract infections with amoxicillin or placebo showed no difference in resolution of the pneumonia. The other thing is we don't x-ray every one of these kids. Okay, pneumonia is a clinical diagnosis. Okay, why would I x-ray a kid with pneumonia? I've heard it. I hear the rails. I know they got pneumonia. Okay, why would I take an x-ray? To prove I'm right and spend more money? Make my local radiologist happy? Why do I take x-rays? The only time you really have to x-ray a pneumonia if you think the kid has more than just a simple pneumonia, like a pleural effusion. But if they have a pleural effusion, okay, you're going to have decreased breath sounds on one side with the pleural effusion, and you're going to hear rails on the other. So then you're going to take an x-ray. Or if there's evidence of a pneumothorax, then you may want to take an x-ray. Otherwise, it's not necessary to x-ray every kid who's got pneumonia. And can we differentiate between bacterial and viral pneumonias? Yes, we can. Okay. Basically, non-bacterial pneumonias have a gradual progression, getting gradual worse every single day for about a week. Okay, that's the typical presentation of viral pneumonias, like RSV. We said they start with an upper respiratory infection for 1 to 2 or 3 days, and then they get progressively worse. Bacterial infections, okay, you have an upper respiratory illness, cough, runny nose, cough, maybe low-grade fever, and they wake up on one morning with 103 fever, cough, and respiratory distress. That's probably bacterial. The treatment is the same for either one. Generally, no antibiotics if you can get away with it, okay? And that's how we treat that's how we treat pneumonias. Every pneumonia does not need an x-ray nor antibiotics. Okay, those are the acute infections. What about the chronic infection. And the first one is tuberculosis, TB. And TB is not gone. It's still around, okay? I mean, worldwide, there are 8 million new cases of tuberculosis every year with 3 million deaths. TB is still with us. In this year, there was an outbreak of tuberculosis in Kansas with 67 cases of active tuberculosis. So tuberculosis is not dead. It remains one of the 10 leading causes worldwide of death in the world, okay? And more important, it's an important case of morbidity and mortality even here in the United States. Historically, Koch identified the TB bacillus in 1882, okay? And then Röntgen, who invented the X-ray, showed X-ray evidence 13 years later in 1895. And it wasn't until 22 years later that we had a skin test, the PPD skin test, the MAN2 test, which could identify patients who have been exposed to tuberculosis. And then we went from 1907 to the 1990s before we had the quantiferon gold, the blood test that we have today that identifies exposure to tuberculosis. Okay. TB, 80% of children under 5 years of age worldwide are infected with tuberculosis. Generally, the majority occur in Africa and Asia, and 90% of kids with TB are not receiving treatment. This means more than 1/3 of the world's population is infected with tuberculosis, which we're talking about 2 billion people who get on airplanes and travel. Okay? Now, here in the US, okay, in the early part of the 19th century, TB gradually decreased. Why did tuberculosis gradually decrease in the early part of the 20th century, the 1900s? We didn't have antibiotics, okay? Because we had improved housing conditions, less overcrowding. When somebody was diagnosed with tuberculosis, how do we treat them? Sanatoriums. Okay, we sent them upstate New York to Lake Placid, where the air was clean and fresh, and they weren't exposed to other people with TB or other illnesses. They got good food, and many of them recovered from their tuberculosis. Till the 1980s, and then we had a massive resurgence of tuberculosis. What the hell happened in the 1980s? What? HIV epidemic. Okay, all these immunocompromised people. Okay, many of them IV drug users who didn't take the medication that we gave them. So we developed resistant strains of tuberculosis. Okay. In 2018, okay, in New York City, the number of people with tuberculosis was 7.5 per 100,000. That meant every time you rode a subway or a bus, you could have been exposed to somebody who had tuberculosis. Okay. A very interesting aside, in the late 1800s, early 1900s, people who emigrated here from Europe to the United States, when they went through Ellis Island, were tested for TB, and if you had TB, you were sent back, which meant everybody who bought a boat ticket from the old country to come here had to buy a round-trip ticket. You couldn't show up here and say, but I'm here and I can't afford to go back, okay? No, you had to buy a round-trip ticket, so if they found TB, they sent you back. It was a great boon for the people who owned the boats. Of course, their boats were basically paid for to and from Europe. They were paid for both ways. You were not allowed into this country if you had evidence of active tuberculosis. Currently, Caucasians in this country who have active TB are generally reactivation of their TB that they got years ago. Okay. Currently, the acute infections are in immigrants, young adults, and children under the age of 5. Okay, are the ones most commonly infected. And the bug that's most commonly that causes TB is mycobacterium tuberculosis. That's the drug that causes TB. Yeah, there are some strains of avian tuberculosis that can cause symptomatology, but not like TB. So, how is TB transmitted? What?
Airborne.
Respiratory droplet. In the 50s and 60s on the subway platforms, there used to be signs, $25 fine for spitting on the subway platforms. Why? Because if somebody had TB and hacked up a huge blob of mucus on the subway platform and spit it out, okay, everybody who walked by were exposed to the airborne bacillus that he was exposed to. So this is how it's transmitted. 98%, not 100, 98% of all TB infections is caused by respiratory droplet. So if you breathe in the bacillus, what happens? Do you get tuberculosis? Does everybody who breathes in the bacillus get TB? No. What happens is if you breathe in the TB, they migrate to the regional lymph nodes, and then the body sets up an autoimmune response and stops the TB, in most cases, dead. Okay? No TB. So how do we know the patient's infected with TB? How do we test for it? There's no cavitary. The patients have no symptoms. So how do we know the patient's been exposed to TB? Okay? Yeah. We do a test. What's the test? The PPD. And what is the PPD? How is it given? Yeah, it's given in your forearm, but how? Sub-Q or intradermal? It's an intradermal skin test, which means if you don't raise the wheel, it's a negative test. And what does it measure?
Duration.
No, what is the test measuring? Your T cell response, because this is the T cells that are, keeping the TB from spreading. If I gave you a PPD with measles vaccine, would you be positive? Of course you would. You have a T cell response to measles vaccine, okay? And if we gave you an intradermal skin test with the measles vaccine, you would be positive because you're all immune. Got ya?
Would someone with HIV though that is infected with TB be positive or negative?
It depends on how bad their immunologic depression is. They may be negative, and we'll talk about what a negative or positive test can be, okay, in just a bit, okay? So, basically, okay, the regional lymph nodes have what's called the primary complex, okay? And the hypersensitivity reaction starts somewhere 4 to 8 weeks after the infection. So it's not immediate. That's why many hospitals want a PPD one and then another one 2 weeks later, because you may be in that intermittent state. Okay. There may be, if there's a delay, okay, in the initial T cell response, that's when you get cavitary disease. So immunosuppressed patients like HIV, okay, or people on immunosuppressive drugs, if they're exposed to TB, they may not have an adequate T cell response. And if they don't have an adequate T cell response, they may develop severe infection. We had a 6-week-old baby with miliary tuberculosis. What does miliary tuberculosis look like? Okay, they call it miliary tuberculosis after the term millet seed. The millet seed is a small grain, and when you look at the X-ray, they don't have cavitary disease. They have these little grains spread out throughout their lung. Okay, well, where the hell did this baby get tuberculosis? We tested everybody in the family, everybody who visited the house, everybody the baby came in contact with, and then they went to the hospital. And one of the nurses in the hospital, this is many years ago, had active cavitary tuberculosis, and this hospital in Brooklyn had to recall all the babies born in the hospital to screen them for tuberculosis. So this is the baby who's immunocompromised, who gets basically miliary tuberculosis. Then you have this active work by the T cells, and you do fine until your immune response drops. So when does your immune response drop? Old age, your immune response drops. Okay, that's why they have the souped up flu vaccine for old farts like me. Okay, when you hit adolescence, I told you immunity drops. So kids who were infected as young children, suddenly their immune system drops when they have active disease, and when they hit puberty and the disease may reactivate. When you get measles infection, measles used to reactivate tuberculosis because it affected your immune response. And way back in the dark ages, okay, we used to skin test everybody for TB before we gave them the measles vaccine because we thought if we gave them the measles vaccine, it might affect latent tuberculosis. So we would give them skin tests. Okay, so what's a positive skin test? The answer is it depends. Okay, a PPD greater than 5 millimeters in diameter is considered positive. Okay, in children with close contacts of tuberculosis. If there's tuberculosis in the household and these have a 5 millimeter skin test and they're young children, okay, a 5 millimeter PPD is considered positive. Okay, and how do you check for positivity of a PPD? What's a positive PPD? You put it in the arm and then they come back 2 or 3 days later. What do you look for? You look for induration, not erythema. And how do you check for induration? With your finger, not your eyes. Okay? And you feel for induration. Okay, so close contacts of people with PPDs, children who have chest x-ray evidence of tuberculosis, they have cavitary disease or miliary disease, 5 millimeters is positive. Children with HIV or have transplants or on immunosuppressive drugs, that's a positive PPD as well. Okay, all of those children, 5 millimeters is considered positive. An induration of greater than 10 millimeters in diameter is considered positive in children under the age of 4, because children under the age of 4 do not have quite as robust immune response as older individuals. Children with medical conditions that increase their risk if they get tuberculosis, like diabetes, renal disease, hematologic disease, or malnutrition, or children with frequent exposure to high-risk adults, or if you've recently come here from a high-risk country. Okay, recent immigration means you're here less than 5 years. What are the high-risk countries that you have to worry about? It's every country except Western Europe, the United States, Canada, Australia, and New Zealand. Any other country under those 5 are considered high-risk countries. I mean, I have patients who go to Pakistan every summer with babies and infants, okay? And they come back, and these are high-risk kids who may be at risk for tuberculosis, and these people don't seem to care about it. TB, I guess, is a fact of life. Okay, so this is one of the things you have to pay attention to. If they've traveled to a high-risk country and they come back with respiratory symptoms, TB should be on the list. And then for everybody else under the sun that we haven't talked about, a positive PPD is greater than 15 millimeters in diameter. Okay, that's basically. Now, what about patients who got BCG? What's BCG?
Okay.
What? It's a vaccine. Anybody know what it stands for? Bacillus calumet guerin is what it stands for. And why the hell do they give BCG to patients?
Other countries,
What?
military or other countries.
Well, they give it in Eastern Europe, okay, but why do they give it? Because the thought was that BCG creates a T cell response like TB does, and by giving them BCG, you may give them a head start on developing a T cell response to prevent tuberculosis. The problem with that, what's the problem with giving a patient BCG? What? What?
Always be positive.
What will be positive? Yeah, the PBD will be positive. If you create a T cell response and we're testing T cells, it's going to be positive. So now your ability to make the diagnosis of exposure goes out the window. So anybody who's had BCG should be screened now with quantiferon gold instead of basically PPD. Okay. Now, the majority of patients with tuberculosis, particularly children, show no signs or symptoms any time of the disease. Maybe they have a low-grade fever, maybe a mild cough. In fact, more than 50% of children who've been diagnosed with TB by severe X-ray findings have no symptoms. I had a mother of a patient of mine. She was also a patient. She was teaching ESL, English as a second language, and one of her kids had active tuberculosis with no symptoms. Okay, she spent hours with this kid, and she subsequently converted to developing a positive TB through this chronic exposure with this kid. Okay, we talked about miliary disease in infants. Okay, and again, symptoms of TB may include again a mild, non-productive cough or dyspnea. Young babies, failure to thrive, night sweats, okay, and anorexia. So, how do we treat tuberculosis? How long do we keep people on anti-tubercular medication? Well, it used to be months to years. Why? Because unfortunately, the TB bacillus can only be killed when it's replicating. So if all the TB in your body decided to replicate at Tuesday at 2 o'clock in the afternoon, we could give you one dose of antibiotics and cure you, but they're not that cooperative. Okay, so we're talking about long-term medication. Okay, recent converters with no X-ray evidence of disease. They have a positive PPD. Okay, they generally have a small population of bugs, and one drug should be adequate. If they have X-ray evidence of significant disease or significant symptoms, they need more than one drug. And then we have to know what the resistance of the bacillus is to pick the right antibiotics. So how do we culture tuberculosis? How do we culture TB of a patient? What? Sputum culture. We tell them, hack up the TB into the plate, and we'll go culture it. It takes 6 weeks, and we'll figure out how it grows. Okay, do that to a 3-year-old, a 4-year-old. How in the world are you going to culture it to get as active, evidence of active tuberculosis? What the kids do when they cough up their sputum? They swallow it. So how are we going to culture it? We take a gastric aspirin. We shove an nasogastric tube down and suck up the mucus and culture it. Doesn't the acid kill the bacteria? Why doesn't the acid kill TB bacteria? Say it.
It's acid.
Right. TB bacillus is acid fast. See, they told you microbiology for a problem, for a reason. TB is acid fast. It's not destroyed by the stomach acid. So you can always get a culture on kids from aspirating the stomach contents, and then you decide which drugs to treat. Now, in the bad old days, we used to give INH to recent converters for 9 months for adults, for a year in children. Okay, good luck giving INH for a year to anybody. Okay, but this is how we treated them because we knew that the replication was minimal. Now they've changed it for recent converters without X-ray evidence of disease. Isoniazid and rifampicin can be given, okay, or rifampin once a day for you can give isoniazid and rifampicin weekly for 12 weeks. Every week for 12 weeks, you can give that combination to recent converters under direct observation to make sure they're taking it, because a lot of these people who have TB are active drug users and they're not going to take the medicine. Or you can give them rifampin daily for 4 months. These are the current recommendations for recent converters. There's just one problem, okay? It can't be used in children under the age of 2. Rifampicin only comes in capsules. There's no pediatric form, okay? And the patients don't weigh enough to get it, okay? So these younger kids continue to get INH, which comes in a liquid form, okay, for 9 months. All right? Complications of tuberculosis, and I've seen these, is TB meningitis is a disaster. Okay? When I was a resident in Kings County in the chronic disease ward, we had kids with TB meningitis, and they were essentially vegetables. Okay? TB can also affect the bones, causing Pott's disease. It can also involve the spine, okay, spinal tuberculosis. And, okay, I had one patient. He went to a boarding school for high school in Wisconsin, and he got sick. He developed ascites, okay. The mother didn't know what was going on. She calls me up, okay, and says, can I bring him back? Because I don't know what they're doing. I said, sure, bring him back. And those bad old days, okay, every patient who been into the hospital got a PPD, no matter what. Every patient. And this kid had a positive PPD. So now he had ascites and a positive PPD. I called the GI guy to do a laparoscopy. And he found peritoneal tuberculosis. That's the other 2%. How did this kid get peritoneal tuberculosis? Because the school in Wisconsin was buying raw milk, okay, unpasteurized milk from the local farmer, and the cow had tuberculosis, and he drank the bacteria in the non-pasteurized milk, and that's how he got peritoneal tuberculosis. So that's the 2% that's not respiratory droplet. You can ingest tuberculosis. Generally, we don't see that anymore because all milk is pasteurized, except for the idiots who are drinking more milk nowadays, okay? And they're at risk for developing infection like this, okay? All right, 20 after, take 10 minutes, and then we'll come back and continue the rest of open. Yep.
So you know how you're saying. When I started, and there was like he had paralysis. He had
Yeah.
Yeah. They knew it was viral. Filled with extra. He had everything. He had all the signs. Yeah, I was like, and put him on subject.
Subject accent.
I was still in
Yes, no, put him on subject accent. Put him on,
I mean, I like that.
Yeah, like some.
But,
Yeah.
I tried to.
They still have to run like.
And the
So
same
what?
man.
They just cover their butt like so that. But they just have stuff like yeah, necessarily exhausted. Whatever they were like 95. I'm like
Yeah.
so yeah, like you work in hospitals and you cover your butt.
I don't, who would make sense? Pneumonia. Right, how old is so that's.
Bro, you know, I was watching at
So, what's the age?
I stopped watching it like 97, right? Because I was okay, maybe you're all
Yeah, the baby has the moment.
woke up.
You want to make sure they're
This one.
It's in the house.
Yeah,
Okay. All right. That's.
That's like.
Yeah.
Last about. I just had a question about our space. You said it was like 110 people get it by 3 years old. So like vaccine source again.
No, they have the vaccine, they should be there.
Oh, so but if now the vaccine is common,
It's not that common, actually.
or like,
everyone I know.
like,
Yeah, well, everybody knows that, but I know a lot of people.
It's only to get it between October and. If you're pregnant in summer,
yeah,
if you're pregnant and you're due in
no,
summer,
it was. I
They don't get
yeah,
it.
right. Only if they're gonna be doing that.
You're only gonna do between October and then the kids go into.
Going back to bed.
When they're like when they're winter again, like when they're a couple months.
Yes.
Okay. And then also another question about like diseases where
I made it
like,
on time.
yeah, there's like
Just for your.
RSV and there's like a bunch after. Should we know every single one? No, they're just me.
Most-
No, you.
They do, they're giving it to pregnant women.
I lived like 10 minutes.
Why don't you get, when the kid is in the house, the kid in the house won't feel like that.
I feel like when they're born.
Yeah, it was always early.
Yeah, you can get it in the.
I know like my office, they always give it, they never get it.
Yeah.
You might have to, if you wanna get it, I don't know. Oh,
Like I know where
stupid. They don't wanna get it in the hospital.
Yeah. A lot of patients.
They don't get hepatitis B in the hospital, either. They say, I'm waiting
The
to
way for
come to the office.
Yeah.
My office recommends they get it in the office, not the hospital.
You want to make the money for insurance?
Really funny. No, I know that some hospitals don't offer it. I feel like I know my mom actually does that. But
Okay. I mean, you get paid, then $5 goes down. In fact, I know when he, okay, he's a practice, and he doesn't give, right? He doesn't give the company.
No.
Okay, because, yes.
Get that cell.
What?
You do that cell in your office?
No,
Yours?
so plus
Because you're gonna run out of, you're gonna overdose hepatitis B. So then you have to go out and check. Well,
You do MMR. I mean, that person doesn't do it.
I do MMR, have some.
No, that I know, but there's some people do MMR.
like buff, those brothers.
I get patients ask for it all the time.
What?
We have patients ask for it all the time.
Is that what I tell them?
Yeah.
Big little box.
But they're all on Medicaid, so they don't pay.
Yeah.
I know the office I worked at had a lot of patients like that, so it was worth it for him to get the whole box. Like, a lot of patients were anyways box.
We had a lot of
Yeah, there's a lot of anti-vax.
We had a 4-year-old without a single vaccine. The doctor turned and said, they can take the shot or get out. And they left.
They won't be allowed to school.
I know, I don't know how they get that far. They're 4 years old already.
The document.
You pay enough, people still pay that.
Right, so there was a student in Queens
In Brooklyn, I know.
that found, like, they saw a medical issue, like, the parents made like a medical form for the year, and they were looking at the dates of the vaccines, they're like, this is the extent of the vaccine. And it's time, so they called the doctor's office, like, does the child have vaccine? And they were like,
You
no,
don't have to pull this out.
they
It's in the registry.
Yeah.
They pulled off, and they're like, that's the vaccine, and they're like, they made it up, they wrote it.
Do you know other doctors I know? Do you know Dr. Dunn?
I don't know anybody.
No?
Basically because I'm too old. Everybody I knew was retired dead. Everybody I taught is retired. But it's a fact.
In Carver?
Right. I don't know, Marine Park.
I know, I live a block away.
But I have to.
Yeah. We have conflict.
Came out of
I don't have any.
We have a lot.
Okay?
But I
They push it off to the point where they outgrow them and they're getting that. They say they only like they did that sales files. Peter and they break it up, so they don't end up getting all four.
It's only two gets started.
Right, and then they must.
It's my pet. If you don't vaccinate your kid and your kid goes to the hospital, you should pay for that. Yeah, that's my attitude.
But honestly,
Patient, the other patient had measles, but that's was patient zero. The doctor was yelling at them, like, I left your kid's life, like, you're the lucky case. That was the worst part. I sat there in that room, I was like,
my heart's still like.
People are stupid. And they're being made stupid by. They believe all the crap.
oh.
But you should see the signs, police.
They want.
I'm actually curious to see it, because I would never fly in my houses.
It says, having done the study research on my own, I have elected not to give my children vaccines, being made aware of things like concussion still exists. My child died from that, diphtheria still exists some more, and then at the end it says, and I will hold Dr. Emmett, his entire staff harmless from any suits if my child dies from any one of the
Oh, so you said you've never seen varicella, right?
Oh, I've seen that.
Oh, you have, you said you did it.
Not practice, but no, I saw, I told you about the varicella I saw with the pregnant woman and
I don't think so.
okay, I saw varicella when I was a regular.
Yeah, all the time.
Okay, I haven't seen clinical varicella in my practice.
Well, my friends, you know, that's.
Here we go. Okay, I remember when, okay, I'm old enough to remember meningitis, okay, chicken pox, okay,
I gotta go.
measles, encephalitis, okay? And, you know, if your kid runs a high fever in the middle of the night, it's not immunized, I don't care what.
I've been one with, the environment.
Bacterial meningitis.
what?
Private species meningitis.
I have no idea. Listen,
I told them, I told them like the follow-up, I didn't see them initially.
I was going to memorize the vaccines.
Because it's on everybody's refrigerator.
I have it memorized, I trained that maid in my office, I have everything.
Okay, it's on every, I'm not gonna make it. Memorize it.
I want to teach that, like, there was one thing that I got done, but then
I
it
was thinking
forgot to.
that I know.
And I
Forgot to ask.
How in depth do we study for it again? How in depth, so there's a lot of information.
Like, there's such passage of, like,
How-
be like scouting.
Yeah. The
I
diagnosis.
need to class.
How do you make,
So.
what's the presentation, what's the diagnosis? That's
What presentation was I
See, when the board questions, you're in the emergency room, and kid presents, this, and this, take it straight out of the. Okay, what's the diagnosis?
No.
That's how it goes in.
Yeah. Type questions, like, more to like.
Every question, everyone.
Yeah, with Sullivan.
Scenario. Every question.
Everywhere.
Regarding the moment that you don't drink antibiotics.
What's the point of that?
Yeah, I've seen people.
Yeah, I was just telling him that my son should
Think
have,
it's-
we said that.
They'll probably.
I've seen so many patients.
It's not better.
What?
You know how many questions?
They usually, I don't know, somewhere around the.
Like, why do they still do that?
Because people practice the way they were trained, depends how old they are, and they don't read and they don't. That's what.
Christina, you know the one that
My job is to be good at, rather than.
It's like
what
if we need
everybody
to know,
do.
this is what we have to do.
I had one fail one of my exams, precisely, and when I went over the exam with them, okay, they were saying, so well, in urgent care, we do.
Yeah.
Well, he's gonna be a chemical clinician, because he's being trained by, okay,
I feel like if there's gonna be a class. If you don't know.
Okay, folks, let's settle down, please.
It's always,
People don't know what 10 minutes is. No concept of time. Okay. So we finished with tuberculosis. Now we're going to talk about the most chronic, lethal, genetic disease of Caucasian people, which is what's the most common lethal genetic disease of white people?
Cystic fibrosis.
Cystic fibrosis. What's the most common lethal disease of black people? Okay. So a lot has happened over the years for cystic fibrosis. A lot of good stuff has happened for cystic fibrosis. Cystic fibrosis is a chronic multi-system disease. It involves particularly pulmonary GI tract, and we used to say, which ultimately results in death, which is not quite true anymore. It's transmitted as an autosomal recessive. Okay, it was first diagnosed in 1938. We know where the gene is. It's on the long arm of chromosome number 7. And in 1989, the gene responsible for cystic fibrosis was identified. There are more than 2,000 known mutations of that gene which can cause cystic fibrosis. And for those who are interested, I downloaded all the genetic possibilities, okay? There are 2,000, okay? Most of them we don't see. Most of them are extremely rare, okay? The newborn screening picks up the 100 most common of the 2,000 causes of genetic abnormalities, okay? And the most common genetic defect is the F508 deletion is the most common. 80% of all cystic fibrosis is due to a deletion of the F508. Okay, and what the heck does a gene do? Well, the gene encodes CFTR, cystic fibrosis transmembrane regulator. Okay, and what is this transmembrane regulator do? It affects chloride ion transport. Okay, that's what this gene is responsible for. Okay, now the genes involved in cystic fibrosis are all the genes that secrete mucus. So it's the lungs, the paranasal sinuses, the pancreas, and intrahepatic bile ducts. And what is involved with this, okay, is the airway surface liquid compartment of the lungs. So the cells of the lungs, the outside of the lungs, the cell wall has this airway level, okay, airway surface liquid compartment. And sticking up into this airway surface liquid compartment are the cilia. Okay, and you know what the cilia do, okay? The respiratory cilia, all right? They move mucus along. They clear out the airway. That's what the cilia do, okay? So the airway surface liquid compartment is made up of the cilia and the periciliary liquid layer. Okay, and as long as the periciliary liquid layer is high enough to cover the cilia work. What happens is, if you have an abnormal CFTR gene, okay, you have decreased chloride ion transport. And if there's decreased chloride ion transport, this leads to basically the activation of the epithelial sodium channel. And when the epithelial sodium channel gets involved, water leaves the periciliary liquid layer. And when water leaves the periciliary liquid layer and it begins to drop down, the cilia stop working. And then when the cilia stop working, now all of a sudden you get increased mucus collection. The increased mucus collection is suddenly infected by Pseudomonas. You get an inflammatory response, okay, and subsequent bronchiectasis. That's why when people stop smoking, okay, they start complaining that their cough got worse when they stopped smoking than when they were coughing, because nicotine paralyzes the respiratory cilia. When they stop taking nicotine, the respiratory cilia stop working, and now all of a sudden it starts cleaning out the airway and they start coughing their brains out. So this respiratory ciliary layer is what's important in keeping the lungs or other areas clean. Now, basically, there are different types of mutations in cystic fibrosis. Okay, I think my notes was 7, but basically there's 3 main factors. There's one called the rusty gate, where the protein attaches to the cell wall, okay, but it doesn't quite open the chloride ion channel completely, okay? It's only partially open, okay? So the flow of chloride ion is sort of decreased and can lead to symptomatology. That's one. Then the other is the abnormal folding of the protein. So the gene produces CFTR, but it's folded weirdly, and because it's folded weirdly, it really can't attach to the cell wall membrane. And the third one, okay, is the early stop sign in the process of making the CFTR protein. It stops too early. And that's the same symptom that we see in Duchenne's muscular dystrophy. It's this early stop sign defect. So those are the 3 major defects that affect chloride ion transport. Now, the symptomatology or the clinical manifestations of cystic fibrosis depends upon, okay, the mutational heterogeneity and environmental factors. So the most important symptom is respiratory. Cough is the most constant symptom of pulmonary involvement. They can develop wheezing due to extensive bronchiolitis, and generally this is most frequent during the first year of life, particularly when they get RSV. And the progression of the lung disease is based upon, okay, the secondary infection. So basically, the rate of progression is the chief determinant of morbidity and mortality, whether you get this respiratory infection or not, okay? The sinuses are almost always opacified because the cilia and the sinuses aren't clearing out the sinuses. But they rarely present with sinusitis, even though X-ray shows opacification of the sinuses. GI symptomatology is not as severe today with cystic fibrosis because we have newborn screening. So we know the kids who are going to have cystic fibrosis 2 weeks after they're born, and we can start GI treatment early on to prevent the complications of GI involvement, like GERD, hepatobiliary disease, pancreatic insufficiency. Frequently, they can get interception, okay? In the bad old days, any baby who has meconium ileus in the newborn period, meaning failure to pass meconium, was thought to have cystic fibrosis until proven otherwise. Okay. So also, okay, the other organ involved is the sweat glands. Okay. And if you have excessive loss of salt in the sweat, okay, in hot weather, okay, or maybe during gastroenteritis, these kids can die. And anytime I read about a kid left in a hot car who died, my first thought is, did he have cystic fibrosis and was sweating excessively? And that's why he wound up dying, because this is how kids with cystic fibrosis die. Okay? So how do we make the diagnosis of cystic fibrosis? What's the hallmark test? It's a sweat test. All right? A sweat chloride. Okay? Now, it ain't so. How do we get sweat on babies? How do we make them sweat? Do we put them in a hot box? We're gonna kill them if we do that. So how do we collect sweat? It's called iontophoresis. We basically induce a small electrical charge across the skin. The electrical charge stimulates sweating, and then we can collect the sweat. But then they don't produce a whole bunch of sweat. It's not a lot of sweat. And then your sweat that you collect has to be in non-salt containing glassware, because if there's sodium chloride in the glassware, you're going to get abnormal readings. So you need specific collection material to do the sweat test, okay? And basically, we do iontophoresis in both arms for 30 minutes, collect the sweat, okay? And there are failure rates depending upon how early you start doing the sweat test, okay? And then any sweat chloride greater than 60 milligrams, okay, is considered positive for cystic fibrosis. Okay, 60 milliequivalents, excuse me, milliequivalents, not milligrams, 60 milliequivalents per liter of sweat chlorides is considered positive. A negative test is under 30 milliequivalents. What the hell between 30 and 60? Okay, I mean, if 60 is positive and 30 is negative, what if your sweat chlorides are 45? Okay, this intermediate one, these people need the genetic evaluation, because these are the ones who may have the other 1900 abnormal genes that are out there that can give you cystic fibrosis. So these are the ones they define them as CFTR metabolic syndrome, because their symptoms may not be as severe as cystic fibrosis, okay, but they may have symptomatology, so that's why they belong in this category, okay? Now, the treatment for cystic fibrosis has gotten much, much, much better. Kids used to die, at 1 or 2 years of age from cystic fibrosis. We didn't have treatment for it, okay? The treatment for it is multidisciplinary. You need nutritional, GI, or pulmonary, depending upon their symptoms, infectious disease for their infections, okay, genetics and endocrinology. I mean, there's a whole slew of treatments for them, okay? Now, in the past, when they first identified the gene, well, we can take this gene and we can put it in adenovirus, manipulate the adenovirus, put the gene in and spray it down the airway. This is when gene therapy became very active, okay? And you spray it down the airway. And it worked. The adenovirus infected the respiratory mucosa, okay? The gene started to work, and the symptoms started to get better. There was just one problem. If you had an adenovirus infection, what would happen to you? Without adenovirus, what would your body do? Would adenovirus continue to replicate? You get an immune response. So then these patients got an immune response and killed off the adenovirus that was working. So the idea of gene therapy didn't work. Okay? So then they started basically looking for biologicals, okay, that would affect this CFTR protein. Okay? And the molecular biologicals out there are either potentiators, correctors, or production correctors. Okay? So what do we mean by that? The potentiators were like the oil for the rest of the game. Okay? If it didn't open up all the way, the drug would increase the opening or the flow of chlorine ions, which would help reduce the symptoms. Okay? The correctors would improve the attachment of the CFTR protein to the cell wall so it could work, and the correctors would bypass the production correctors would bypass the stop sign. Okay? And these are working. Okay? And they're working, the first one that came out was the potentiator. It was either Captor, it was called Kaleido, okay, and this was the grease for the rest of the gate, okay. Then they hooked it up with Lumacaftor, okay, and this helped it. So it was a combination of helping the protein attach to the cell wall and lubricate the rest of the gate. I have a cystic fibrosis patient in my practice. He is graduating from the Culinary Institute of America. He has never been hospitalized. Okay. He has never developed severe pneumonia. They knew both parents were carriers for the F508 gene, so he was started on therapy very quickly. Okay. And he drove by the students who rotated through the office nuts because when he came in, I said, I'm leaving the room. Give him the list of drugs you're on. Okay, because there were about 25 drugs he was taking. He was taking either Caftor or Lumacaftor, okay? He was taking inhaled steroids, inhaled antibiotics. He was taking bronchodilators and inhaled steroids. And incidentally, he had OCD and ADHD, so he was on medication for that. Also, I mean, his list of drugs went all the way down the line. But he was never hospitalized. He never had a severe infection. He never had documented pneumonia that I know of. And it was the pneumonia or the infections that kill you. So if you can keep lung function working, this kid did remarkably well. So this is when kids used to die in the bad old days, okay, they used to die in infancy, okay, and then now they say that the median cumulative survival rate is 32. This kid has never had any severe disease. I expect him to live quite a while. Now, how it's affecting his reproductive ability, I don't know yet, okay? But this is what's going on. So you're going to see these kids, okay, live long into adulthood with the drugs that we now have for cystic fibrosis. It's truly remarkable to see the difference from when I started to now, okay? This is one of the big things in medicine that we're seeing today with the drugs that are out there, okay? And they say starting CFTR modulated therapy early on. If you know this kid has cystic fibrosis, you start it as early as the kid who's 1 year old. Start giving these drugs because the earlier you start, the lower the risk of developing all the complications that tend to kill you, meaning infectious. So this is what you're going to see. Okay, so that's cystic fibrosis. Then we go to asthma. Okay, now asthma is a symptom complex, you know that, but caused by exaggerated responsiveness of the respiratory mucosa, of the trachea and bronchi, okay, to various stimuli manifested by difficulty in breathing, narrowing airways, and the hallmark of asthma is it is reversible with treatment. Okay, with appropriate treatment, asthma basically is reversible. Okay, despite that, okay, asthma in children is a major pediatric problem. It's still responsible for acute emergencies, chronic respiratory disease, and despite all the treatments we have today, okay, we still have hospitalizations and emergency room visits that continue to increase, and mortality from asthma still remains high. Kids can die from asthma, so the message here is asthma is not a benign disease. Now, the pathophysiology of asthma basically is number one, you have bronchial hyperresponsiveness. Okay, the bronchial hyperresponsiveness results in smooth muscle constriction, which narrows the airways. Okay, but the other thing that happens with asthma is there's inflammation and there's edema, and the inflammation and edema results in thickened mucus plugging, okay? And the big one is long-term airway remodeling, okay? If you ignore asthma, okay, we can have long-term remodeling. What do we mean by long-term remodeling? Well, untreated asthma has inflammation, not just bronchospasm. And if you don't treat the inflammation, long-term inflammation can result in thickening of the basement membrane, subepithelial collagen deposition, and smooth muscle hypertrophy and hyperplasia. And all of those are irreversible once it starts. So it means treatment for asthma should be aggressive. Treating the inflammation as well as the bronchospasm, which is a problem because treating the inflammation means very often long-term care, and patients don't like doing anything long-term care. So we live in a world of immediate gratification. Give me my albuterol inhaler, my bronchospasm goes away, I'm happy. But what's happening down on there when the bronchospasm stops and the inflammation continues is what causes chronic problems, basically with asthma. So what are the triggers? Well, common viral infections of the respiratory tract does it. People get colds, they wheeze. Okay? Allergens. All right, I'm going to insult people now. Animal dander. Okay, dogs and cats. More cats than dogs. Okay, more male cats than female cats. And cat lovers are weird people. Okay? If I say to a patient, your dog is probably triggering the asthma, they say, okay, I'll get rid of the dog. Cat lovers, I've had the cat longer than the kid. Okay, keep the cat, get rid of the kid. But they both can't live in the house. Unless, if you're a cat lover and you're worried about your kid getting asthma, have 12 cats, not one. Because kids who live out on farms don't develop as much asthma, basically, as kids who grow up in an apartment with only one cat. And if you're going to have one cat, then you should have one of these coon cats. I don't know if you've seen pictures of coon cats. They weigh about 35, 40 pounds. Okay? If you have a cat that big that sheds hair all over the damn house, your kid will be sort of protected from allergens from cats. Okay? So I'm sorry to the cat lovers I insulted, but they're a pain in the butt to treat. Okay? Other forms of dust mites can do it. Roaches, not the roaches themselves. It's the dead roaches. When the roach dies and the carapace of the roach breaks up into pieces and becomes aerosol, that's what triggers the asthma in the kids. Okay? Mold can do it. I had one patient who bought a gorgeous house on Hewlett Bay, right on the water, and the kid developed asthma. So what's my first question? Do you have mold growing? Oh yeah, the basement's full of mold. And that's why it keeps freezing. They sold the house, the asthma went up. So mold can trigger basically asthma. Okay. Seasonal, you all know, pollens, grasses, trees, weeds can all trigger asthma. And then we have sulfites. When the heck do you get sulfites to trigger asthma? Somebody should know. No alcoholics in this room. Red wine has sulfites in it. In fact, red wine has a label on the back of the bottle, contains sulfites, because some people are sulfite sensitive, and if they drink red wine, it will trigger asthma. But there is another place where there are sulfites, where there are no labels. Okay? Have you ever wondered when you cut a head of lettuce and you leave it on the counter, it turns brown in an hour or two? How come it don't turn brown on salad bars? Salad bars, the lettuce and the stuff lays there for hours, never turns brown. You never thought about it. Okay? You cut up your lettuce, it gets brown in an hour. In salad bars, it lays there all day long, doesn't get brown. That's because it's bathed in sulfites. So if you have somebody who's an asthmatic and you don't know what's triggering their asthma, they may be sulfite sensitive, and you have to ask where they eat, because if they're eating in salad bars, that may be the trigger. Environmental, tobacco smoke can do it. Air pollutants, ozone, sulfur dioxide, wood or coal burning fireplaces can trigger it. Okay, strong or noxious odors, perfumes, hairspray, cleaning supplies. I had one kid whose asthma I couldn't control, and then of course the mother comes in and says, "I figured out what's wrong. Please tell me." She said, I came home one day when my cleaning woman was still there and the whole house stunk from whatever she was cleaning my house with. I stopped her from using it. The asthma got better. And then I had one father, okay? His kid started wheezing when he was an infant. And I couldn't figure out what the heck. I mean, I looked this kid up for every rare disease that causes wheezing and it was all negative. He comes into me and says, Hey, doc, I figured out what was wrong. I said, Okay, please tell me. He says, we had a clothes dryer in the house that wasn't vented to the outside. You mean you used a clothes dryer that wasn't vented, so every time you dried the clothes, the wind flew through your entire house? He said, yes. So now that's on my list to ask. Do you have a clothes dryer that's not vented? Who thinks of asking that question? Now I asked the question because I knew that that was a possibility, okay? We know that exercise can do it, crying and laughing and temperature changes, okay, can also trigger an asthmatic response. Asthma is the most common chronic disease, chronic illness of childhood. Okay. There are 8 to 9 million people in the United States who have been diagnosed with asthma, close to 235, 240 million people worldwide, again, have been diagnosed with asthma. It's the number one cause for hospitalization of children. It's the leading cause of missed school days, okay, at least in 1998. African Americans have a higher admission rate and higher death rate. That's probably because they have poorer treatments for their asthma. Okay. Now, my notes say most children will have their first episode of asthma before the age of 6. And that probably means their first acute episode of wheezing. Now, basically, kids are telling you they had asthma long before they have their acute episode and they should be treated. So what's the most common cause of symptom of asthma? Cough. Coughing when? Nighttime. The nighttime cough, okay? There's only 3 things that cause nighttime cough: asthma, GERD, and sinusitis. Those are the only 3 things that cause the nighttime cough for kids. So, if a mother comes in complaining that the kid has a cough, my first question is the kid up all night coughing? If the answer is yes, this kid has reactive airway disease. Now, my choice is either to go to the house at 2 o'clock in the morning and listen to the kid when he's coughing his brains out, or treat him with a bronchodilator and see what happens. And I choose to treat him with bronchodilator rather than go to the house at 2 o'clock in the morning. And if their cough gets better, okay, at night, then I know he has reactive airway disease. He doesn't have asthma because asthma is a chronic disease. But very often these kids, okay, who have had the nighttime cough, they start coughing their brains out when they start going to school and start getting sick. So now they're in daycare and they're coming in with coughs. And now when I see them coughing during the day, now I hear the wheezing. So now we can start the treatment for reactive airway disease before they have their acute episode of wheezing. In my opinion, none of these kids should ever wind up with acute wheezing in the emergency room unless somebody's not following, instructions. Bronchiolitis, if we talked about in infants, if I saw a kid who was an ex-preemie who had bronchiolitis in October, November, and now it's a year later, and he's coughing at night, okay, this kid has asthma, okay? And a report just got, we knew it. Anybody in practice knew this, okay? But somebody did a study and they said, yes, bronchiolitis, especially in young children, can make them susceptible to developing asthma as they get older. So these are the things we keep in the back of the head because we can start treatment early. And if we start treatment early, we can prevent the chronicity due to the airway remodeling that I talked about. Okay? As long as we started basically early with the treatment. Okay? So what are the risk factors for kids to develop asthma? Males are generally more wheezing than females, okay? Ex-preemies are at greater risk for getting RSV, therefore they're again at greater risk for developing asthma. If there's a family history of asthma, it's easy. If there's a family history of atrophy or atopic dermatitis, because atopic dermatitis is a hypersensitive reaction of the skin. And when the atopic dermatitis gets better, very often these kids wheeze because it's a different end organ responding to the hypersensitivity rather than the lungs. So very often as we get their eczema better, the kids start wheezing. So we're aware of it. Kids with allergic rhinitis, again, they are allergic. They're at greater risk for developing asthma. Hyperresponsiveness without a cold, okay? Exercise-induced wheezing, the nighttime coughing, okay? Lower socioeconomic status increases the risk, okay? Cigarette smoking. I mean, if I have mothers or fathers who smoke and their kid is an asthmatic, I threaten to report them for child abuse because cigarette smoke is one of the biggest triggers of asthma. Fortunately, less and less people are smoking, so we don't see so much of that anymore. And then a sedentary lifestyle. Okay, sedentary lifestyle can increase the morbidity and mortality of the asthma. Why? Because the thought is vigorous exercise has a protective effect on the lungs in asthmatic kids. So you want them out running around because you want them deep breathing with exercise. And if they wheeze when they exercise, you pre-treat them so that they don't wheeze during their exercise because the deep breathing rather than sitting playing video games all day long, will improve the control of their asthma. Okay? So, asthma is a chronic disease, so you need chronicity to make the diagnosis. So, when I'm treating these kids for hyperactive airway disease, I don't call it asthma because they're not that sick. The symptoms aren't chronic. As the symptoms get progressively worse, then I will label them as an asthmatic, okay, if they do indeed become that, okay? So, you have cough, wheeze, shortness of breath, chest tightness. So, the initial is the expiratory wheeze. Very often, you can tell that the kid is wheezing without a stethoscope, just watching them breathe, okay? Because if you're wheezing, what is your FEV1 like? What?
Low.
It's decreased and lower. And they have a prolonged expiratory phase. Okay? So you watch them breathe, and instead of breathing normally, they're breathing. Okay? So why do we start with expiratory wheezing and why don't we wheeze both ways? I mean, we have airway narrowing. Why aren't they wheezing in both directions? This is why I gave you last week how we breathe. Okay? What happens? How do you get air into the chest?
Diaphragm goes down.
Down and produces what? Negative pressure. Well, when you produce negative pressure in the lungs, what is it doing to those narrow airways? It opens them. So they have no trouble getting air in, but when they breathe out, the airways narrow down further, and now you have expiratory wheezing as the first sign of asthma. And then, because they can't get all the air out, they have air trapping. Okay, because again, it can't get all the air out. So then your body uses the accessory muscles of respiration to try and increase the AP diameter to create greater negative pressure. And when it can't do that, then you start wheezing in both directions. So if you have wheezing in both directions, you know it's more severe than just the expiratory wheezing. And then what happens when the wheezing stops? You die because it means you're not exchanging any air at all. So that's the progression of basically asthma. Okay, first it's the expiratory, then it's basically inspiratory and expiratory, and hopefully they never stop wheezing. Now, the other thing is with examining kids, okay, who are wheezing, you tell them to breathe for you. And kids know when they have asthma, if they take a deep breath, they're gonna cough. So they breathe like this. Instead of taking a deep breath, instead of going, and then you can hear the wheeze, they sit there and going, and you don't hear the wheezing. The trick on these patients is to compress their abdomen when they breathe out. With the stethoscope on the back, and as they breathe out, hold their abdomen. And when they take a deep breath, just hold it for a couple of breaths, and then all of a sudden let go. And when you let go of the abdomen, it's and then they cough their brains out and you can hear them wheeze. I mean, that's the trick to get them to wheeze because they ain't dumb. They know if they're taking deep breaths, they're going to cough their brains out. Okay. And you may not hear the wheezing. So instead, watch their expiratory phase, see if it's prolonged. If it's prolonged, you know they must be wheezing, even though you don't hear it. And then you can try to induce basically the wheezing. Now, have you had pulmonary yet? Yeah, okay. Have they talked about grading of asthma? From intermittent to mild persistent, moderate persistent, severe. I mean, that's how we grade them. Okay. Because the diagnosis depends on your treatment modalities. Okay. If a kid has intermittent asthma, okay, mild intermittent asthma, basically it means, okay, they just wheeze when they're sick, or they have exercise-induced bronchospasm. They just wheeze when they exercise. Okay, they're not going to have long-term effects from their wheezing. So the patients with intermittent asthma, okay, all their treatment modality needs is a short-acting beta agonist. Okay, albuterol. Now I can tell you in the dark ages when I was a resident, we only had three things to treat asthma: epinephrine injections, steroids, and aminophylline intravenously. These are the only three things we had to treat asthma. And I had one gem of a patient who was allergic to aminophylline, the vehicle in aminophylline. So when he came in wheezing, the only thing I could use was IV isoproterenol, and it had to be done in the ICU. So I sent him home in those days on oral albuterol. Okay. And the PDR said experience with children with oral albuterol was limited to 46 patients. And that was it. I had to use it because I had no other alternatives. We were afraid of putting kids on steroids because the theory was once you put an asthmatic on oral steroids, you were never getting them off. So you never wanted to put them on that. That was the problem. And then we progressed. We have a whole slew of drugs now to treat asthma. Okay. And most of it is by inhalation. So, number one, for intermittent asthma, we use inhaled albuterol. And when you give a patient inhaled albuterol or write a prescription for it, you're in urgent care or the emergency room, make sure they know how to use it. What's the first thing you have to do with a albuterol inhaler? How do you use it? What?
Shake it, prime it.
You have to shake it. If you don't shake it, all you're getting is the propellant and you're not getting any of the albuterol. That's number one. And I can't tell you how many people, oh, they gave me this inhaler, show me how to use it. Didn't shake it, didn't get the medication. Okay, so that's number one. Number two, in children, watch them. I've seen kids being given the inhaler. It goes in their mouth, comes right out their nose, and never makes it down the airway. Okay, and most people can't walk and chew gum at the same time, let alone use a metered dose inhaler. So if you're writing for one, okay, make sure they know how to use it. Now, if they don't know how to use it, they make spacers, which are tubes with a valve, so you can shake it, spray it in the tube, and then they can take 3 deep breaths and get the inhalation, basically, rather than doing it, during inhalation, because most people can't do it. So beta agonists for the mild intermittent asthma, and patients do not get refills on their beta agonists. Because once you get past mild intermittent asthma, when you get to mild persistent asthma, now you need a controller to prevent the secondary changes in the airway. And people don't like using controlled drugs, so they don't use them. And they continue to use just their inhalers. Okay? Well, if you continue to use just your inhalers, okay, they eventually stop working. Okay? They become less and less effective without controllers. So when people basically are using, now they have mild intermittent asthma, and we're using controller medications, if they call for a refill for their albuterol and don't call for a refill of their controller meds, I don't give it to them. And I make them come to the office so they can get yelled at and pay a copay. Okay? And every time they don't use it, they come in and pay a copay to get yelled at. And hopefully they can eventually use it. So basically, what are we using for long-term control of medications? Well, they're all anti-inflammatories of one sort or another. Okay? Low-dose inhaled steroids. But low-dose inhaled steroids for mild intermittent asthma, you have to use all the time. And most patients don't want to use inhaled steroids all the time, even if they're low dose. And remember, when people are worried about using steroids, inhaled steroids come in micrograms, okay, and oral steroids come in milligrams. There's 1,000% difference between the two. So low dose, so inhaled corticosteroids have very little secondary or long-term effects. So you can use long-term low-dose inhalers all the time. Or I started using medium to high-dose inhaled steroids, and I said to a patient, if they need albuterol twice in one day or 2 days in a row, they go on medium to high-dose inhaled steroids for 2 weeks, and then you can stop it. And studies have shown that basically I was right. Okay, you can use medium to high-dose inhaled steroids for 10 days to 2 weeks after a wheezing episode, and it has this protective effect. You can also use, instead of using inhaled steroids, you can use leukotriene modifiers like Singulair, okay? And Singulair is pretty good. It's an oral pill. They take it every single night. And of course, taking it every single night, people don't want to do. Okay, there's been some bad press about Singulair, so people have stopped wanting to use it. So they're using inhaled steroids instead of Singulair. I used to use Singulair all the time, and I used to use it in kids as young as a year of age with really no complications. But TikTok tells patients they're going to have it, so we do it. Okay, moderate persistent asthma. Now you need regular inhaled steroid use, okay, and maybe theophylline. Now, long-acting theophylline got a bad rap, okay? When oral theophylline first came out, we used it, and we used to scream at parents because we'd given the prescription for theophylline, okay? And they'd come in with their kid wheezing, and we'd do a theophylline level, and it would be 0. And we said, you're not giving it to them, and they'd swear up and down that they were giving it to them, and we said, well, their blood levels are normal. And when theophylline, which the kids had a miserable taste. It tasted awful. It had to be given in big volumes. None of the kids wanted to take it. Then it came out in granules. We could sprinkle it on food, so we had better, compliance. And then we could do in-office theophylline levels. Okay, not just when they were wheezing. And we found out that these kids metabolize theophylline very rapidly, more than we ever thought they did. And we had to use doses that we thought were toxic, and these kids just metabolized the stuff. So theophylline got a bad rap. It's still a good drug if you're stuck, but generally inhaled steroids are the way to go. And if you have severe persistent asthma, then use everything under the sun. Okay. Now the problem with everything I'm telling you and what to use is the insurance company, because there are now basically the Global Initiative for Asthma, it's called GINA, came out with a stepwise way of treating asthma, depending upon the age of the patient, how severe the asthma is, what you should use for long-term asthma treatment. Okay, very good, very nice way to do it, except there's something called basically the PBM. So what PBM stands for? Pharmacy Benefit Managers. And they determine, okay, they work for the insurance companies and they tell you what drugs they're going to pay for. And what drugs are they going to pay for are the drugs that the company kickbacks the most to the insurance company, not what's best for the patient. And this is where the big problem comes up in managing asthmatics. Okay, so you have a kid who has moderate persistent asthma. Okay, the basic treatment for him, okay, is a combination of, they call it smart therapy. Okay, basically it's a combination of single maintenance and reliever therapy. It's a inhaled steroid and formoterol, which is a medium to long acting albuterol, and it can be used every 4 to 6 hours. So it's great. They only need one inhale. They need an inhaled steroid with a short to medium to long term acting bronchodilator, and they all need it. It works great. The insurance companies won't pay for it. So this is the problem with treating them. Then they need 2 inhalers instead of one. Okay, and then we run into problems writing prescriptions, and they won't even cover some of the other inhalers. It becomes a real mess trying to find out which insurance company will cover which drug. And there's a revolt going on about PBM, so maybe they won't be there when you're out there in the practice sphere. If a kid has exercise-induced asthma, there's a long-term beta agonist, okay, which got a lot of bad press when it first came out, okay, because it takes 30 minutes to an hour to work, and it lasts 6 to 8 hours. So if a kid's going to run around on the soccer field, you give it to him an hour before he goes to play, and he never wheezes, and you finish his exercise-induced asthma. And if you had long-term wheezing episodes, you could take a long-term beta agonist and it would last for 6 to 8 hours, and you wouldn't abuse your metered dose inhaler. There's just one problem. It's not rescue medicine. So if you're having an acute episode of wheezing, you can't use this long-term beta agonist, because by the time it works, you'll be dead. So there were deaths from this long-term beta agonist because of bad clinicians and stupid patients who didn't want to pay for 2 inhalers instead of, they just wanted to pay for one. So it got removed. Now the long-term beta agonists are combined with inhaled steroids for chronic use. The patient still needs rescue medicine if you're going to give it to them. And basically there's a rule of twos. Okay, if a patient is getting up basically more than twice a night coughing, they're using their inhaled metered dose inhaler more than twice a week, or they need more than 2 metered dose inhalers more than twice a year, they need controller medicine. That's why you never give them refills on their metered dose inhalers. At what age can you give a kid a metered dose inhaler to use himself, to carry it? 6, 7, 8, 12, 14. Okay? He has to be a responsible adolescent. 12, 13, or 14. And I can tell you, some allergists gave a patient of mine, 8 years old, a meter dose inhaler to carry. One puff was great, two puffs were better, three puff cardiorespiratory arrest and died. Okay, they have to know how to use it. And then you got to be careful with adolescents because, hey, you want to get high, you can try my meter dose inhaler because it increases your blood pressure and your heart rate, and you get high on my inhaler. Okay, you need a responsible adolescent to be allowed to use it. And most of the schools, if they label a kid an asthmatic and he's going to need to use a meter dose inhaler in school, will not let them carry it. It must be in the nurse's office and it must be used under supervision because of episodes of something like this. Younger kids, we give the inhaled medications through nebulizers. Okay, very young children, they're not going to cooperate. They're not going to take deep breaths through a spacer. They do make spacers with masks on them. And I haven't had much success because you put the mask over the kid's face and he starts screaming bloody murder and doesn't take deep breaths. So you use the nebulizer. The nebulizer takes 20 minutes. So as the kid gets older, you say, when you take 3 deep breaths, I can give you this. You don't need the nebulizer. And most older kids will do it. And then you can use the spacer to give them their medication. Now, you should have a warning here also, okay, about inhaled anticholinergics. They are using anticholinergics in older children and asthmatics. Okay, it's out there for the treatment. Okay, the problem with anticholinergics, okay, is that there are increased risks for arrhythmias in people with asthma. So if you're putting kids on an inhaled anticholinergic, you have to be aware that a lot of these kids, okay, particularly at higher doses of anticholinergics, can develop a significant arrhythmia, and it should be used basically with caution. Okay, all right, that's asthma. Then we talk about foreign body aspiration. Okay, aspiration of foreign matter into the airway. The incidence of foreign body aspiration hasn't changed over the years. 10% of the kids under the year of age, the majority of them are children under 3 years of age, and 1/3 of all aspirations are nuts, particularly peanuts. The message here is you don't give young children peanuts. You don't give 2-year-olds chewing gum. Okay, you don't give older kids raw carrots, hot dogs, dried beans, popcorn, sunflower seeds. Kids are playing baseball and they watch all the baseball players chewing sunflower seeds and spitting them out. On the ball field, they want to do the same thing. They can aspirate sunflower seeds. Watermelon seeds are just as big of a problem of aspiration. Grapes. Give a kid grapes, you better peel them. Make sure there are no seeds in the grapes that you're giving them. All of these go down the airway. Now, here's the good one, okay? Where's the most common place for aspiration? Where in the airway? Yeah, that's what they taught you, right? Right main stem bronchi. And why is it the right main stem bronchi the most common cause of aspiration? They tell you because it's straighter than the left because the left goes over the heart. It's a load of crap. Because first of all, you assume that when the kid is choking, he's erect. And not lying on his left side. Okay? Or leaning to the left when he aspirates. Number two, if you talk about the people who pick all this crap out of the lungs from aspiration, there's no predilection to the right or left main stem bronchus. Okay? It can go down either one. Okay? So I know what you've been taught. But when you talk to the people who do the bronchoscopies to clear out the lungs, no predilection, right or left main stem bronchus. That's where the majority of them show up. It can all get stuck. It can be stuck in the trachea. It can be stuck in the larynx. Okay. Most of this stuff does not show up on X-ray. Okay. Food doesn't show up on X-ray. Plastic doesn't show up on X-ray. I had one kid, the mother thought she was choking on a plastic piece of an older kid's toy. She brought him in. I put a tongue blade in the kid's mouth. He gagged and up came the plastic piece. And it wouldn't have shown up on X-ray if it went down. Okay? So again, it's either mainstem bronchus, and the symptoms depend upon whether there's partial or complete obstruction by the foreign body, whether the foreign body did direct trauma to the mucosa, or it was a result of mucosal damage. If it did direct damage to the mucosa, you're going to get hemoptysis. They're going to cough up blood. If they did a peanut, okay, it's going to lay down there for a while, and then the peanut is going to damage the respiratory mucosa, and that's where you're going to get the symptoms. Okay, the majority of patients with foreign body may present with respiratory distress, dyspnea, or a cough. Okay, if they have inspiratory stridor, it means it's located in the upper airway. If they have expiratory wheezing, then you know it's down in the lower airway. Okay? And so basically, to make the diagnosis, you need to suspect it. So the kid comes in with this chronic cough, maybe some respiratory distress. Okay? You have to ask the questions. Do you give chewing gum? Does the kid eat peanuts? Does he eat popcorn? You know, sunflower seeds, all the things I went over to get an idea of what there may be down there to know whether you have to worry about foreign body aspiration. All right, and the last thing we talk about, okay, is how to make a diagnosis of a patient who comes in with a cough. And we don't do sophisticated CAT scans or MRIs. We're talking about clinical judgment. You listen to the chest and you make the diagnosis upon what you hear and what the breath sound like. So, if the patient has an expiratory wheeze when you listen, it means there's something within the chest. If the patient has an inspiratory wheeze or inspiratory stridor, that means it's in the upper airway. It's outside the chest. If he's wheezing in both directions, you have to figure out which one is more prominent. That's number one. And then what does the nature of the wheeze sound like? If it's a monophonic wheeze, single note, it's a large airway. You know, large airway obstruction, like crew. Okay, single note. Okay, foreign body aspiration, maybe a tumor or vascular ring. Monophonic, large airway. If it's a musical random polyphonic wheeze, it means that there are big airways and small airways opening and closing at different times. Okay, such as bronchiolitis, cystic fibrosis, asthma, and pulmonary edema. So the nature of the noise is going to give you an idea what's going on. Then the patient has a cough. So where do we have cough receptors? Well, obviously we have them in the airway, the trachea, the bronchi, the alveoli, the pleura, all have cough receptors, okay? We also have cough receptors in the pericardium, stomach, and diaphragm. But we also have cough receptors in the nose, sinuses, and ear canals. And kids love to shove things in orifices. So if a kid comes in with a chronic cough, just don't listen to the lungs. Look in the ears for a foreign body. Look up the nose for a foreign body, except when it comes to foreign body in the nose, if it's in there for a while, you really don't have to look up the nose to make the diagnosis. If they've had a foreign body up their nose, they're going to stink to high heaven, and the whole room is going to stink to high heaven when they have a foreign body up their nose. But also transilluminate the sinuses. Maybe he has a sinusitis, and that's what's giving him the chronic cough. Okay, so you look for places where there are cough receptors. Then what's the nature of the cough? If it's loose, okay, if the kid has a postnasal drip kind of cough, okay, mucousy cough can be a postnasal drip, sinusitis, or maybe a sufferer of lung disease. But if he has a sufferer of lung disease, he should be febrile and sicker. If it's a dry, brassy kind of cough, okay, then it's tracheal or large airway disease. Paroxysmal cough, okay, is pertussis or foreign body aspiration. Okay, chlamydia can give you a staccato cough. There's the tight, dry cough of reversible airway disease, asthma, or GERD can give you a tight, dry cough. Okay. And if he has stridor, then you know it's extrathoracic, meaning it's croup or foreign body obstruction. If the cough disappears with sleep, it's psychogenic. They cough all day long, and when they're sleeping, they don't cough. There's no significant disease. I had one patient, the mother comes in with a chronic cough, and this was her cough. This was her water bottle. That was a cough. Okay? This kid is crazy. This was a psychogenic. So I took a big sheet and I tied her up. I tied her chest up. And she didn't cough for 40 minutes. No cough whatsoever. Because you can't take a cough if you can't take a deep breath. Unless you have some pathological problem. Then I took the sheet off. Okay? So I told the mother she needed a shrink. This is not pulmonary. She does not need a chest x-ray. She does not need, a sonogram or a CAT scan. She needs a psychiatrist. She didn't get a psychiatrist, but the cough stopped and she went into constipation. And as a result of a constipation, she had urinary accidents. So then she was seen by the GI guy, okay, and the urologist to take care of her urinary and GI symptoms. And she didn't have a copay, okay, so she could go any place she wanted because she had no copay. I could identify her chart from across the room because the chart was this big with all the consultations she had. And this kid wanted to study medicine. I can't wait till she gets sophomore syndrome. It has every disease under the sun because she needs a psychiatrist and she was nuts. This is the typical history of psychogenic coughs that we see. And if it's really psychogenic and you tie them up, they don't cough. That's how you make the diagnosis. So you can lead a horse to water. You can't get everybody to go to psychiatric care, unfortunately. Okay? Then check the chest. Okay? Basically, put your finger in the suprasternal notch and feel the trachea. Is the trachea in the midline? Or is it being pulled to one side? If it's being pulled to one side, you either have an atelectasis, where the trachea is being pulled, or you have a pleural effusion that's pushing the lungs over and the trachea is deviated. Okay? Then you can send them for an x-ray because now you know there's a potential problem going on. Okay? Do they have decreased breath sounds on one side? Okay, if they decreased breath sounds on one side and normal breath sounds on the other, you either have an atelectasis or a pleural effusion. Okay, then you can go in and take the chest rate. If the patient is tachypnic and only retracting on one side, okay, why aren't they retracting on the other side? Need a chest X-ray to find out what's going on. Okay, but do the examination first. Okay, and then basically, okay, take a history. Is the cough associated with feeding? If you have a baby who every time they're fed is coughing their brains out and getting into respiratory distress, they may have a tracheoesophageal fistula where every time they're eating food, the milk is winding up in the lungs. Okay? Take a history. It's associated with feeding. Do they have GERD after feeding as a cough? Okay, is it a nighttime cough? Is it after exercise? Is it paroxysmal? What's the quality of the cough? Are there any known allergens? Is anybody else in the family sick? Are the kids up to date? Are they coughing up blood? This is a history that'll let you know what's going on. And then age factors related to coughing. Children under a year of age, okay? If the immunizations aren't up to date, you have to think of pertussis. They haven't been immunized. Chlamydial infections, congenital abnormalities of the airway, GERD, okay? Aspiration syndrome, okay? And then RSV and cytomegalic virus. Children 1 to 5 years of age for a cough, well, we said mycoplasma is up there, okay? Sinusitis, we talked about a nighttime cough for that. Postnasal drip, foreign body aspiration, asthma, GERD, and maybe bronchiectasis. In children over the age of 6, okay, smoking. Yes, children over the age of 6 smoke. And if you don't believe me, there's this, it's TikTok or a video of a 3-year-old obese Filipino boy smoking cigarettes. So kids can smoke cigarettes, okay? You have to ask about it. Now, cigarette smoking is significantly dropped down, so that's, sort of decreasing. Psychogenic reasons, mycoplasma, sinusitis, foreign body, habit cough, okay, bronchiectasis, and then Tourette's syndrome. What's Tourette's syndrome? Okay. Anybody know what Tourette's syndrome is? What? It's an uncontrollable tic, okay? This is the kids who come in with Tourette's syndrome. That's Tourette's. They've already been to the allergist. They've already been to the ENT. Okay. Nobody can find anything wrong with them, and they're making these noises, snorting and clearing the throat and anything else. Okay. The way you make the diagnosis is you ask 2 questions. Say to the kid, "Can you stop doing this?" And they all can. If you ask them to stop, they will stop making the noise. And then you say to them, "What happens when you stop, when I tell you to stop doing this?" And they will all give you some sort of history that they feel like something building up inside of them, and they have to do this to release whatever is building up inside of them. That's Tourette's, okay? Then you say to the parent, which parent has OCD? And one of them will, okay? Because Tourette's is along a continuum of benign tic disorder syndrome of children, Tourette's, and OCD. And somebody in this family has OCD, okay? And you say to the mother, does your milk have to go on the top right shelf of the refrigerator? And if somebody puts it back on the left, when you open it up, you take it and put it back on the right-hand side? They'll know exactly who they are when you ask them this. Or do you say, does daddy have a hissy fit when somebody puts his tools back in the wrong place? Okay? Because somebody in the family has OCD. Okay? Now you have the diagnosis of Tourette's. What's the treatment? Ignore it. The more you pay attention to it, the worse it gets. Okay? Now, unless the kid is severely disruptive in class, you tell the teacher to disrupt, he's not sick, he doesn't have pneumonia or a cough, this is his Tourette's, leave him alone. Okay? There are surgeons who have Tourette's syndrome. Okay? And when they're focused and doing the surgery, nothing. And then when they're done, they go into the doctor's lounge, tick like crazy. And then they can go back out and do the surgery because when they're focused, it disappears. I had one kid with Tourette's syndrome, okay, and we ignored it. And then he became a teenager. And instead of having the vocal tic, he combed his hair. And all day long he was combing his hair. So everybody thought he was vain as hell, okay? But it was more acceptable because he was combing his hair and wasn't making loud noises. okay? Because the treatment for Tourette's is not very good, and we don't want to basically sedate these kids when we're basically doing it. But that's how you diagnose Tourette's. And I can tell you, I have Tourette's in my practice, and I just write notes to the school ignore it. It'll eventually change or go away or something like that. Okay? So, when a kid comes in with these kinds of vocalizations, before you send them to the ENT and before you send them off to the allergist, ask them if he can stop it, because they all can. Okay? So that's Tourette syndrome. Okay? When you come to adolescence, okay, psychogenic etiologies like we're talking about, RSV, mycoplasma, chlamydia, pertussis, all ages, passive cigarette smoking, pollutants, reactive airway disease, cystic fibrosis. But basically, you go through a differential diagnosis before you do all the fancy stuff. Now, the one other thing that's out there, okay, is post-viral cough. Somebody comes in and they've been diagnosed with flu, okay, and they come to you and they say, I got the flu, I took the Tamiflu, okay, but I'm still coughing my brains out. Oh, you have a diagnosis of bronchitis. Here's amoxicillin or a Z-Pack. A week later, they're back, okay? 10 days later, doc, I'm still coughing my brains out. Oh, your bronchitis must be terrible. Here's Cipro. They take Cipro, they come back, they're still coughing. What does that tell you? They didn't need the antibiotics to begin with. First of all, most cases of bronchitis do not require antibiotics to begin with. So what the heck is going on? Okay? Well, viral infections can increase airway reactivity and produce a cough that can last 8 weeks. It doesn't mean they're sick. It doesn't mean they have bronchitis. They have airway reactivity, and any exposure, change in temperature, exposure to cigarette smoke, exposure to pollutions or something like that can trigger this cough. Okay? Well, the virus damaged the respiratory mucosa and made the respiratory mucosa sensitive to this. So how do we treat the airway sensitivity? With bronchodilators. That's what these patients need. They don't need antibiotics for their bronchitis after the flu. They've had a severe viral infection. They have increased airway sensitivity, and anytime they're exposed to any sort of change in what they're breathing, they're going to cough their brains out, and they're going to cough their brains out for 8 weeks. And just because you give them a bronchodilator does not mean they have asthma. They have a damaged respiratory tree secondary to the flu or viral infection that they had. Okay? And I am a big fan, okay, of using a combination of a long-acting bronchodilator and an inhaled steroid. So I give them something I can there, okay? And I tell them to take it twice a day. And in 10 days, they're better. Because we treated the airway hyperreactivity with a bronchodilator. We've helped healing with the inhaled steroids, and they get better. So this is the one message I give you. You do not give these post-flu patients antibiotics because now you assume they have bronchitis because they don't, and they don't need the antibiotics. And you know me by now that I'm an antibiotic not nihilist. Okay? I don't use basically antibiotics. And now the last thing I'll talk about is chest pain. Okay? And we have 2 types of chest pain, okay? Which ones do we worry about? Non-cardiac chest pain or cardiac chest pain? Non-cardiac chest pain generally occurs in younger kids like 11 to 13 years of age. If they're younger than 11, the first thing you want to rule out is organic disease if they're really having chest pain. But these preteens and teenagers usually come in with chest pain, okay, with a normal physical exam. And the description is the pain is either described as sharp or stabbing. Okay, and it's the same with and without activity. Okay, doesn't change whether they're active or they're not active. It's been there a long time. And there is no shortness of breath with the pain. There is no diaphoresis with the pain. There's no nausea, palpitations, or syncope. If they have any of those, if they have shortness of breath, dizziness, nausea, diaphoresis, palpitation, or syncope, this is not non-cardiac chest pain. You really have to worry about cardiac chest pain with these kids. Okay. Now, what's the etiology? Okay, idiopathic, most of them. They've been there from weeks to months, same with and without exercise. That's the most common cause. Musculoskeletal, you know, these kids very often say that it started with participation in sports and it gets worse with activity and inspiration. Okay, and the idiopathic and the musculoskeletal, okay, are the ones that we see. And this is osteochondritis. Okay. And when they're complaining of chest pain, you say, where does it hurt? And usually they can put their finger on the one spot where it hurts. Okay. And you say, does it hurt up here? No, it hurts here. Does it hurt down here? No, it hurts here. Does it hurt on the other side? No, it hurts just there. That's your typical costochondritis. And if you're diagnosing costochondritis, and I showed you this, I think I talked about this before, okay, when I was talking about scoliosis. Did I mention that? Not? Okay. When you talk about costochondritis, okay, don't worry about here. Turn them around and look at their back. Because if you look at their back, they are going to have a curve in their back. Okay? And this scapula is going to be lower than this one, and their hips are going to be lower here. Okay? And at the apex of the curve, right there, is where the rib is being pushed around anteriorly, and this is why they're getting costochondritis. And costochondritis hurts more when they take a deep breath. Why does it hurt more? Because the rib is moving up with a deep breath, and that's why it hurts. And that's how you diagnose costochondritis. Now, everybody has a short leg. I don't care who you are. Everybody has one leg shorter than the other. You know how I know? Watch how people stand. You all stand on your short leg. Okay? Because if you stand on your long leg, the short one don't reach the ground. So everybody stands on their short leg. And when you ask kids, show me how to stand, that's how I stand. How do you stand with your friend? That's how you stand. No, you don't. So then you have to watch how the kid relaxes. And when he relaxes, everybody stands on their short leg. If they refuse that, lie them on their back and match their malleoli. Everybody has one leg shorter than the other. It's about a quarter of an inch. Now, when I'm an osteopath, when I see these kids, I treat them, the chest pain goes away, okay? And then I tell them to put a lift in the shoe. Because if you put a lift in the shoe, it equals out the pelvis, then the curve goes away, and the costochondritis disappears. And that's how we get rid of the chest pain. I had one cop, he was a cop, okay? He was 23 years old and kept coming in, I'm having a heart attack. No, you're not, okay? And I tell them, I don't want to see your face in this office again unless you're wearing a lift in your shoe. Don't even come in and complain. I'll get you drop dead on the street. You're not having a heart attack. You're wearing a lift in your shoe. And 5 months, I never saw him. And then it was August or July. And he came back, I'm having a heart attack. And he showed up in my office in uniform and a vest, the whole thing, full uniform. I'm dying, okay? He came in July, I'm having chest pain again. No, you're not. You're wearing flip-flops. Okay? So this was him. Okay? And he's nuts. Okay? He now has a 12-year-old and an 8-year-old. And he came into my office. The laceration of his finger taken, piled off in the bathroom. And he's saying, you're fixing it. I'm not going to urgent care. So, okay, I fixed his finger, and while I'm fixing it, he's sitting in the treatment room, taking pictures of himself, sitting on my exam table, so he can show to everybody that he's 28 years old and I'm still taking care of him. This is crazy, Stephen. But so if you have a patient who comes in with this sort of chest pain and they don't have any of the bad signs and symptoms, look at their back. You may not have the ability to treat them initially, but you can show them up, look at the curve, and when these kids bend over, the curve disappears. And when they sit down, the curve disappears. Because when you're bending over or sitting down, you're taking the effect of the short leg out of the picture and the back straightens out, so they don't have scoliosis. And I can tell you, I see this all. I 3 times a week I'm fixing somebody with chest pain. Okay, they're coming in, I fix them, they go home, put a lift in the shoe and leave me alone. Okay, some of them listen, some don't. If the back is fine, you have to think of pulmonary diseases that may be doing it. Okay, they may have reactive airway disease or pneumonia as their etiology of their chest pain, and then psychogenic is out there. And psychogenic, it hurts. Where does it hurt? All over. What makes it worse? Everything. Okay, that's more psychogenic than everything under the sun. Okay, obviously, if it gets worse with eating, it's heartburn. If it gets worse eating with heartburn, the patient has GERD. Okay, ischemic heart disease is the least common cause of chest pain. Okay, less than 5% of kids who you're going to see with chest pain have cardiac problems. And how is it described? It's described as brief, crushing, unremitting, and mid-sternum. And it gets worse with activity. Okay? And if it's associated with shortness of breath, dizziness, nausea, pallor, syncope, diaphoresis, or palpitations, you need a cardiac workup. Okay? So, what are the etiologies? Well, basically, if they have an anomalous coronary artery, that usually doesn't give chest pain to begin with. But if they have hypertonic, hypertrophic cardiomyopathy, okay, these are the kids who drop dead on they're playing sports on the basketball court or what have you. Usually there's a family history of it, okay? And when you're taking, asking for participation in sports of these kids, you should take a family history of possible heart disease. Um, and then you may want to limit their participation in sports if they're having symptoms or there's a positive family history. Aortic stenosis, well, you should be able to hear the murmur of aortic stenosis. Okay, Kawasaki's disease usually does not cause chest pain, but it can cause cardiac artery aneurysm. If they're using cocaine, that can give you chest pain. Okay, and then basically if it's inflammatory like pericarditis or myocarditis, these patients will have symptoms of basically heart disease. Okay, they will have a friction rub, maybe evidence of heart failure. They have a gallop rhythm. Okay, but one thing, okay, that may give them is arrhythmias, and these kids may complain of a racing heart, palpitations, chest discomfort, and basically connective tissue disorders can also give you cardiac disease. But these patients should have some sort of indication that they have connective tissue disease other than just their cardiac. So the message here is the majority of patients that you're going to see come in complaining of chest pain, it's not their heart. Okay, most of them basically, last for a long time. They can pinpoint it, look at their back. That's extremely common with costochondritis. Okay, they taught you about costochondritis. They just didn't teach you how to treat it. Okay, and this is one of the ways to treat it. Just put a lift in their shoe, and that will take care of it. Okay, I will stop here. Okay, I'm not going to see you next week, or am I?
Oh, yeah, no, we're on
You're on vacation
Yeah.
next week, right? So I will see you basically in 2 weeks. Okay, when I come back, we will do basically nephrology. And nephrology will take about 2/3 of the lecture. And that's the end of your second exam. I know you haven't even taken your first one, but that's the end of the 5 series for the second exam. Okay, and then we start on neurology. And neurology is a big, big subject uh, section. Okay, so enjoy your vacation. Woman. Good luck on the exam. Now I will tell you when is the exam? Wednesday. Karen usually sends me the results the next day. Okay, Wednesday night or Thursday. I go over the exam immediately. Okay, I go through all the questions. If half the class got the question wrong, then basically it's a bad question. Okay, and I throw it out. Okay, because I'm not perfect in making up exam questions unless you kill the patient. Okay, if you take the patient with acute epiglottitis and send them to X-ray, and everybody kills them in X-ray, I am not throwing out that question. I'm just telling you, that's the kind of